10 o'clock at night, still on Wednesday for me. But it is a pleasure to host this virtual event dedicated to advancing our collective understanding of pediatric medicine and child health. Today's lineup features distinguished clinicians, researchers, and young professionals sharing valuable insights on a wide range of pediatric topics from endocrinology and ophthalmology to behavioral health and surgical management. Let's begin this enlightening session. Our first speaker is Dr. Shruti Mishra from India. She is a pediatrician, and she will be presenting on autism, transition from childhood to adolescence, challenges and guide for professionals. Thank you, Dr. Mishra. Join me in welcoming her. Do you need any help sharing the screen?
No, thank you. Thanks a lot. Good morning, everyone. So
Hello.
I'll just share my screen and then let me start presentation. Yeah. So
Do you need any guidance? Is your presentation open already?
yeah. Am I visible now? My presentation is visible?
Not yet.
Okay. Just give me some time. Is it visible right now?
No, not yet.
Okay. We'll start from the beginning, maybe. Left or right? No. There.
Now we can see it.
Yeah. Okay. Sure. Fine.
And if you press play, it'll just be the one slide.
Sure. So is it visible now? And the slides are also moving, I guess. You can see the moving slides also, changing slides.
Yes, we can see your main slide and then we can see your all of them on the left side.
Sure. Thank you very much. Thank you for the introduction. So I am Dr. Shruti Mishra. I am a developmental pediatrician. So basically, I work with children with neurodevelopmental issues. And when I was thinking about the topic, so I thought, like, why not? And I deal with a lot of children into the spectrum, into the autism spectrum disorder. So because this is a child health and adolescent conference, so I thought, why not deal with something which is related to transition? Because we have been seeing children like in India, definitely, and in the tertiary care sector like us, we have been now pushing a lot onto early identification and intervention. I was very glad to hear a lot of topics in the conference this time, which has been discussed on the same. And so I thought, why not something related to transition? So by the time parents start and reach us, so we are definitely working a lot on early diagnosis, as I said. So we have been starting to working with children as less as 13 months also. But the challenge here is people are into interventions, therapies, running from one doctor to another. And by the time it comes to the adolescents, so many of them are exhausted. The support system is not there for many of the adolescent age group. And as we know that children who are into the autism spectrum, so transition is a challenge. So I just wanted to discuss, and puberty, adolescence in itself comes with huge challenges, which can be because of physical, emotional, behavioral, and social changes. So today we will be discussing in the next 20 minutes on what are the challenges and how we can support our children into the spectrum during their transition from childhood to adolescence and beyond. So coming on to biological and physiological changes, as we see, the onset of puberty in itself brings a lot of physical changes in the body of a child. So there is some hair growths. There will be a lot of changes in the breast, changes in the genitalia for the children, for the male and females respectively. So in itself, a lot of changes in the body, and kids and adolescents are not able to understand and not able to accept many a time these changes. Sensory sensitivity to bodily changes can also happen. So because of the growth of hairs, specifically sleep disturbance, which we already see in adolescents, also in the neurotypical adolescents, also the body circadian rhythm shifts a bit. So definitely it comes with a lot of challenges. Then comes hygiene difficulties. So how to take care during menstruation, how to shave, how to use the deodorant for proper hygiene. So these are all the challenges that are faced by adolescents and their parents because of the biological and physiological changes. Next, coming to social and emotional changes. So there's a lot of social complexity and peer expectation that comes with it. So children who are definitely higher functioning and into the spectrum, they do start to understand the difference between themselves and other peers. And many a time, this awareness of self and differences may lead to issues like anxiety, low self-esteem. They want to initiate friendship, and it is known that in children into the spectrum also, it is not like earlier thought that they don't want to include, but they don't know how to do it. So that's the problem. And other peers also, acceptance from their side may also be low because of a lot of challenges with respect to pragmatic language difficulties, limited social communication. Interest in opposite sex, again, a very natural thing, but without boundaries. Adolescent may not know how to approach other opposite sex, how to have friendship with them, how to initiate conversation, which in itself is a challenging task. Next, coming on to cognitive and executive functioning. There is a lot of demands that grows exponentially with respect to higher academic skills as well as organizational demands, the adolescent and the later childhood. So children are expected to do a lot of tasks by themselves, which the teachers later on do not provide the support so much, may not be able to. There is difficulty managing routines. A lot of tasks exponentially increases. There may be, in addition to that, emotional dysregulation due to hormonal changes. So again, as we know, executive functional deficit is commonly seen in children into the spectrum. So how to support them, I'll be discussing in the next few slides. Communication challenges. So if we see the language trajectory of children into the spectrum, for the first 10 to 15% of them may have a functional language, but for them also the pragmatic language difficulty is there. For example, understanding sarcasm, understanding humor might be difficult for them. And 30 to 40% of children may have functional language, but it will be into the moderate range. Moderate language deficit may still be there. So either they may just be limited to speaking sentences for needs. And we know that the function of communication is not only for needs, it's definitely to express interest, for socialization, to express their feelings. And if the child or adolescent is not able to do that in itself, it leads to a lot of frustrations and leading to emotional and behavioral issues in children. So strongly, I'm a very strong advocate of augmentative and alternative methods of communication, specifically for population or children who are neurodiverse and minimally or non-verbal. And for them, the AAC system must evolve. So if we talk about alternative and augmentative methods of communication, there are two criteria. One is the low-tech devices, which may be in the form of communication boards, picture books, but it has its own limitations. So going ahead to the non-tech or to the high-tech systems. So we have in India, Avas, there are many people using Prolog Tube. So these should evolve with age. It should be changing and it should be advancing so that children are able to communicate better. And definitely once given a mode of communication, they do wonders, because deficit in communication does not always mean a cognitive deficit. So that's a very important point that we should remember. So if given proper methods of communication, then definitely they do a lot better with respect to behavior, with respect to socialization and communication. Family and environmental changes. So children and adolescents are themselves anxious because of these changes and transition, and parents themselves are also anxious because they don't know whether how much they should protect an adolescent, or they have to give them independence. How much is the transition, how much they can be able to give. Transition change to schools, many a time it brings new challenges. So there was a child, 13 years old, recently, like 3-4 weeks back. They have shifted from one of the metro cities in India to other, and the child is a single child and very difficult to adjust. And parents are seeing a lot of aggressive behaviors in the child, like in addition to hitting also, and they are not able to figure out why this is happening. So again, transition. The answer to this is the child should have been prepared first, and maybe very gradual transition may have been done. And now we will have to see and provide support to the child, like what best can be done for him to keep him engaged and to help him let out his feeling. And again, the communication is still a challenge. The child is having a moderate language deficit and still speaking only in phrases, but is not able to express his feelings. So again, the idea of working on communication skills early. And as I said, need for a structured transition planning. So every time I talk to my patients, I tell them that if you suppose leave me a new city today without telling me how can I progress and what I have to do, then it becomes very difficult for me. I become very anxious. But if you give me a proper layout, okay, after this you have to go there, you have to reach there, you do this hotel has been booked for you, and then you can come back on this day or date, then it will be a lot easier for me. So transition planning is very, very important, and use of social stories for helping them transition, for helping them with the expectations, what are the societal expectations, how we greet other people, maybe how we initiate the communication, the social skills training aspect. We'll be dealing with that. So that is very, very important. And it should not be a surprise. Any change should not be a surprise for anyone, whether it be neurotypical or neurodivergent children and adolescent. And mental health comorbidities, we already know that children into the spectrum, they already have a high chances of having anxiety, depression, OCD, emotional coping challenges, body image concerns, and eating disorders. So we have to monitor for that very well, and we have to see any coexisting health condition, and it should be treated. Support should be provided accordingly. Adaptive and independent skills. Right from day one, when the child comes to me, I always emphasize that our ultimate goal is to make the child independent, and we should be able to make them learn to do their activities of daily living age appropriately. So also there comes a gap between cognitive ability and daily skills. So a child or an adolescent's cognitive skills may be higher, but the daily living skills may be impacted. For example, because they don't know the time concept. So it's not only limited to eating, dressing, undressing, grooming by themselves. It involves a lot of things. So the time concept, the money concept, once they go out, if they want to purchase something, how to do that, how to make choices between the purchase, materials, how to know this is good, this is bad for them. So that is also very important. So it is not only limited to the daily activities, but more social skills is involved, daily living skills is involved, and it should always be a priority for parents and the caregivers and supporters, for the professionals to maintain, to make that adaptive and independent skills the priority for any child of any age. So if it is not there, definitely there will be difficulty with money, transport, self-care. And there is also a chance of having a risk of learned helplessness. So what does that mean is the child may be able to do that, but because he has not been given the opportunity, or the family or the caregivers has been doing it for them. So what happens is children have become helpless in those situations. If there's no support, they don't know how to do it by themselves. Then again, the emphasis on reducing the prompt comes. So we always say, parents, if you are prompting for everything, don't make the child prompt dependent. So gradually we have to reduce the prompt and help which we are providing to the child or adolescent, so that we are able to work towards more independent skills. And definitely with it comes behavioral challenges in the girls, specifically the higher functioning children. So they are able to know and identify the difference, and masking comes. So what is masking? So they learn gradually, they are able to read the social cues, and they learn mingle with other people. But it brings out a lot of burnout. So they may force eye contact even though they are not comfortable with that. They may try to mingle on the sarcasm and jokes with them, but that they not be very comfortable with that. So it causes burnout and anxiety for girls. They may try to reduce their repetitive behaviors by themselves. In boys, more of a externalizing behaviors are seen, like aggression and irritability. Social withdrawal may be there. There may be sexual challenges. So in a study, there was reported that children with neurodiverse children, they have a lot of sexual challenges that will be there. Okay, so how to provide support? Now the most important aspect is, how do we provide support to them? So this is very important. So always early social communication interventions that is being targeted. So at a very early age, we have to work on social skills training. We have to like, which can be used, even though evidence does not favor the use of, like, not favoring, I would say, does not support that social skills training in itself has a lot of evidence. It is in providing the inputs to the children, but in clinical settings, in general settings, we see that it does helps a lot. So there are other areas like peers and buddy system is very important, that can be incorporated in the schools. So buddy system means a neurotypical child can be paired up with a neurodivergent child, and the neurotypical can help them in the social interventions, maybe for approaching to other kids, how to play with them, involving them in their daily play skills. That is very important. Structured school transitions. So when and how, before going to the next school, where are they going to go? How is the support in that school system? It should not be a surprise for the parents also. Once the child enters that school, I don't have any support. It should not be there. And again, life skills training, so which is not only limited to daily skills, but going on with more support, and how to do the daily activities, how to maybe just book a cab for them, how to purchase something. So I purposely tell them that every weekend you take them to the store and ask them, for the children definitely who have some capabilities of communication, to work on that aspects also. So protective and supportive factors, mental health monitoring is again very important. So looking out for signs of withdrawal, signs of anxiety, signs of depression is very, very important. Now comes first thing is, because we were talking about the transition, so preparing for puberty is something which needs to be done. So again, early communication. So communication for puberty or bodily changes should not come directly in the older childhood and adolescence. From the very beginning, we ask parents to use very appropriate phrases and words for the body parts, and be clear and concrete with the communication. Depending upon the child's understanding level, we can teach them, like, okay, what is the function of each body parts, and how do we go about it, and suppose how do we there can be visual aids like this that can be used for hygiene concept. So many of our children will be visual learners. So if we show them these visual prompts, it works wonders for them. And parents themselves have to, yeah, it works because I know what is to be done next, what is to be done next. And it will help me to know how do I go about for the daily hygiene techniques also. Modeling by self, the father can show the child how to definitely shave. Mom can also help the child with the menstrual hygiene process that will be there. So modeling is a very good technique to teach children, not only neurodivergent, again, I would say from day one of our life, we are modeling for our children. So whatever we do, they are doing it. So definitely it should be as much positive as possible. And going ahead, the concept of public and private has to be started at a very, very early age only. So because we can use again these visual aids, I always tell parents that in adolescent, many of the parents, they will come with the problem like my child will go to the bathroom very regularly, want to be in a closed room, or sometimes he will touch his private parts also. So this is something which is very natural and cannot be avoided. Yeah, but yes, we need to make them understand that, and stopping is not going to work, but we need to maintain and make them understand that this particular behavior is good where and not good where. Where can they go if they want to touch their private part, or maybe change their dress or take a bath? How is the personal space? So we should not never cross other people's personal space. You can just go and touch anyone. You will have to take a permission. And modeling again. So if we are telling the child to do the same, we have to again help them model the same. We have to model them with them. So in the daily household also, we should not just go and do these things. We'll have to maintain our limit. There can be what we call it as some family rules kind of things. So because for some children, the rule works better. So this way we can train our children. So there is this beautiful smiley pain skill that we talk about. We do use in children also for any kind of pain. So girls who are minimally or non-verbal and they are not able to communicate their pain or distress during puberty. So these kinds of pain skills can be used to know, okay, she is having difficult mind difficulty. So maybe a hot water bag works for her. She's having very severe pain. So in that case, like we can use some analgesics for her. And most important point is safety, personal safety. What is good touch, what is bad touch? Very, very important, because our neurodiverse children are very vulnerable, and from a very beginning, depending upon the child's understanding. So this is a whole training session. If I go on talking about it, for the personal safety, it is a complete module that we do here. And it is like very important for the personal safety and even internet safety. So there will be a lot of adolescents who will be using internets. So where, which site, whom to talk, what is the danger signs, how you can identify this person. We should, if there is someone bullying you or saying bad words or due to something that you think is not good, please immediately report to the parents. So what they are watching, and maybe sometimes co-viewing also helps them to understand that, okay, this is some stuff that is that can be a danger sign for you. So you have to be very, very careful about it, always being as much possible open to the adolescent. Role of medication, yes, in cases where the parents or the caregivers are not able to handle it, is leading to something injury to the child or adolescent themselves, or the person surrounding them are at the danger of getting injured. If it is very severe depression, severe anxiety, which may not be managed by other support systems, then yes, role of medication is there. We do use for aggression and irritability, risperidone, the atypical antipsychotics, risperidone and aripiprazole. Sometimes we do use depression. Yes, definitely SSRI, the first line agents can be used. So in my clinical setting, definitely if it is anxiety, depression, I do take inputs from the psychiatrist also, and then only I go ahead with the medications for depression, anxiety, or OCDs. And we all know that role of multidisciplinary team is very, very important. Medical management, definitely, as I discussed, family therapy. So we will have to take family as a team. And puberty can be very stressful and challenging for the parents also. So parent training, parent education is the first thing that we should go ahead. And then what is expected, what is normal, what is not normal, and how do we go ahead to train them, train the children at home. And definitely legal and financial planning at this stage should be started. So how independent your child is, whether there is any support system for them or not, what is the financial planning, what about education, what happens after the parents are not there. So these planning should start at a very young age, definitely during the adolescent period. And the role of definitely cognitive behavioral therapies and other psychotherapies are there for children who have other mental health issues in addition to the autism spectrum disorder. So overall, the key takeaway for this is adolescence is a very critical period and it requires a lot of proactive supports. And we have to focus on emotional well-being, communication, and independence as well. And it definitely requires a collaborative approach amongst the family, school, and the professionals. So with this, I'll end my talk. Thank you very much, and I'm open to any questions that will be there.
Thank you, Dr. Mishra. I was wondering about the AAC stuff. Is there like iPad applications that can easily be accessed?
Yes, doctor. Yeah, there are iPad application. In fact, the AWAS system that I'm talking about, it's AVAZ. It is iPad is easily available on iPad and Android versions also. So here, so whichever is comfortable for the parents, it can be used. So only thing we insist that it should be a device which is a child's communication device. So there should be no other things on that device, and the child has to carry it everywhere. That's the first prerequisite, and it should be made safe if the child has a habit of throwing things, because the child needs to understand that this is our communication device.
Thank you. Any other questions from the group? Thank you for your presentation. Our next speaker is Dr. Amjad Olayan Al-Harbi, and I apologize if I mispronounce names, from Saudi Arabia, a
No, it's a great, thank
pediatrics resident, presenting on primary amenorrhea in adolescents, a case-based approach to disorders of sex development. Thank you, doctor.
Hello, good morning, everyone. Can you see the screen that I'm sharing?
Yes, we can.
Okay, great. So I'm gonna review a case, and then with the review of the case, we're gonna approach a very rare disorder of sexual development. So let's go through the case and see how to approach a similar case. So, okay. So I have a 17-year-old adolescent girl who presented with a concern of amenorrhea when her younger sister attained menarche while she hadn't still attained menarche. She's development starting at 13 years of age. She also reported development of sparse pubic and axillary hair about 2 years ago, which is at 15 years of age. So it is important for us to approach patients who present with a primary amenorrhea that we think about the differential diagnosis in this age group and rule out some of the possible differential diagnoses. So in this case, I ruled out galactorrhea, headache, visual changes, polyuria or polydipsia or anosmia, which comes with central causes of primary amenorrhea. We also ruled out cyclic abdominal pain, hirsutism, acne, or deepening of the voice. There is no weight loss, no restrictive eating behaviors or excessive exercise, no low mood or stress, and no hair loss called intolerance or fatigue. There is also negative history of any chemotherapy or radiation before. So when we go and review her detailed history, past medical history, she's obese and she had a past episode of facial palsy. Surgical is unremarkable. Neonatal history was also uneventful and unremarkable. Ministerial history, as mentioned, we have a breast development at 13 years of age, axillary and pubic hair at 15 years of age. She's using only prednisolone for the past episode of facial palsy, and now it is being tapered down. She doesn't have any allergies. Immunization is completed. Developmental, she is appropriate for her age with excellent performance in school, and she's aspiring to pursue medical school. Nutritional history, as mentioned, no restrictive eating behaviors. When we go to the family history, which is really important in these cases, we notice that we have positive consanguinity. Parents are first-degree cousins. The mother is 40 years old and she's healthy. The father is 55 and he has dyslipidemia. She has 2 brothers and 3 sisters. The first sister who's 15 years old, and this is the one who attained menarche at 12 years of age. Second sister is 13 years and no menarche yet. 9 years with no menarche. No family history of infertility or ambiguous genitalia or delayed puberty, though she has a distant maternal cousin with a primary amenorrhea, and this is really important. Social history was unremarkable, very caring family. Moving on to her examination, we had a very well-looking adolescent girl who's cooperative and engaging appropriately, answering questions, and she had no dysmorphology. Vital signs were all normal, and it's important for us here to look to her blood pressure because of Cushing or congenital adrenal hyperplasia. When we look to her growth parameters, we can see that her height is 172 cm, which is way above the expected for her mid-parental height. Her maternal height is 155 and paternal height 157. So the expected was 149 and she's 172, which raises a concern. Weight is 98, so it's above the 97th centile, and she's considered obese. Her genital examination showed normal female appearance genitalia with both labia majora and minora well-formed, clitoris normal in size, and an open meatus. Vaginal opening was also clear, no bulging or bluish discoloration. Tanner staging was 5 for the breast and pubic hair was 2. Puberty, and then it was the rest of her examination was actually unremarkable. Cranial nerve examination was intact because of the anosmia risk. The rest is all unremarkable apart from severe acanthosis nigricans. She did not have any hirsutism, acne, or increased pigmentation. So let's take the summary of this case. So I have a 17-year-old adolescent girl who was previously healthy, except for a past episode of facial palsy treated with prednisolone, came with a concern of amenorrhea, though she developed a breast around, let's say, 4 years ago, and pubic and axillary hair 2 years back. Positive history of on and off back pain, no other associated symptoms. Family history revealed positive consanguinity with a distant maternal cousin with a primary amenorrhea. My examination showed no dysmorphology, normal vital signs. The weight was above the 97th centile and the height was 90th to 95th centile. She had severe acanthosis nigricans and Tanner staging was 2 for pubic hair and the breast was Tanner 5. She did not have any symptoms for hypergonadotropic, suggestive of hyperandrogenism. And she had a normal-looking external female genitalia. Okay, so to approach this case, we know that we have a primary amenorrhea, which is usually defined as either you have a 13-year-old with absence of menses and also absence of secondary sexual characteristics, or you have more than 3 years past thelarchy, and this is what we have in this patient. Then we know that the normal menstrual cycle need 4 anatomical and functional structures to be normal, which are starting with the hypothalamus and then the anterior pituitary, ovaries, and finally the uterine or the genital outflow tract. So any issue with any level of these from the hypothalamus to the outflow tract may result in primary amenorrhea. Let's approach a case, generally speaking, with primary amenorrhea. You always look to your secondary sexual characteristics, which are the breast or pubic hair development. If you don't have any secondary sexual characteristics, we call this hypogonadism, which can be caused by either hypogonadotropic, which means it's central from the pituitary or the hypothalamus. This is usually seen in constitutional delay or functional hypothalamic amenorrhea, or any tumors or infiltrative disorders or Kalaman syndrome. If we're talking about the other mechanism, which is hypergonadotropic hypogonadism, this is when you have high FSH and LH and the anterior pituitary is secreting the hormones, however, the ovaries are not responding. This either means that you have premature ovarian insufficiency or you have a disorder of sexual development, or you have an autoimmune disease or aromatase deficiency or 17-alpha hydroxylase deficiency. So the synthesis of the estrogen is impaired by the ovary. The second case, which is similar to my case, when you do have secondary sexual characteristics, she does have breast development and pubic hair. So I go to either anatomic or disorders of sex development, probably Müllerian agenesis or complete androgen insensitivity syndrome, or any anatomical causes. The other thing that we need to keep in mind is endocrine causes, which are like polycystic ovarian syndrome, hypothyroidism, Cushing, and diabetes. The clues that I have in my case is that her height and weight are above the 90th centile, which means I don't have any functional hypothalamic suppression. She does have a breast development, which means I do have estrogen, either from the ovaries or from peripheral synthesis. Sparse pubic and axillary hair, which means I don't have signs of hyperandrogenism because they would come with hirsutism. And she's not progressing in puberty. She entered the puberty and then it was arrested. Obesity and severe acanthosis nigricans indicate insulin resistance. There is a family history which may suggest a genetic cause. So my differential diagnosis was initially top of the differential disorders of sex development, especially that this girl is extremely tall compared to her siblings, which can either be related to disorders of androgen synthesis or action, like complete androgen insensitivity or gonadal dysgenesis. The other thing that we need to keep in mind is anatomical causes like agenesis of Müllerian duct or obstruction of the menstrual outflow from either imperforated hymen or transverse vaginal septum. Endocrine causes, I have to consider polycystic ovarian syndrome, especially that this girl has insulin resistance signs and she's obese. However, usually polycystic ovarian would come with secondary amenorrhea rather than primary amenorrhea. We worked up this girl, and you can see that we had a normal CBC, normal chemistry, we had a normal liver profile, and then we did lipiid profile, which was almost unremarkable. Thyroid function test was normal. Cortisol was not done in the morning, so we cannot rely on it a lot. Prolactin was within acceptable. Hemoglobin A1C was elevated in the pre-diabetic, which is 6 here. Then we did the hormonal workup. You can see that the 17-hydroxyprogesterone was normal, androstenedione and DHAAS were all within normal, which indicate that adrenal androgens are intact in this patient. I had a high FSH and LH with low estradiol, which indicates that I have a hypergonadotropic hypogonadism that we discussed earlier. Testosterone was low, which is normal for a female patient. However, she had the high anti-Müllerian hormone, which indicates the presence of a testis with functioning Sertoli cells, which is abnormal in an adolescent girl. We did an ultrasound and it showed uterus and both ovaries were not visualized and for further assessment. So I have an absent uterus in a girl with primary amenorrhea. This can be either Müllerian agenesis or disorders of sexual development. So next we did a pelvic MRI, which actually revealed a small blind-ended lower vaginal pouch with absent uterus, tubes, and both ovaries. And we also had bilateral, slightly hyperintense structures noted in the left inguinal canal and the right lower pelvis, which are compatible with undescended testes. So this makes us think of mainly disorders of sexual development, not Müllerian agenesis, because not only the absence of the uterus and ovaries, it's also the presence of the testes. So we did the genetic workup and it revealed a male karyotype, which is 46XY. FISH study was done and it revealed that all cells showed a signal pattern indicative of a male XY chromosome. The gene panel for this patient showed a homozygous VUS and LH CGR gene, which is associated with autosomal recessive Leydig cell hypoplasia. And we did the segregation analysis for the whole family. And you can see that both parents are heterozygous, 2 brothers are heterozygous, 1 sister unaffected, and 1 sister heterozygous. And unfortunately, the other sister is homozygous. So she's also affected as my patient, but the other sister had a female karyotype, 46XX. This tells us that just to understand what's going on with these patients, the LHCGR is basically a transmembrane protein, as you can see, and it responds to either HCG or LH. And in males, it results in androgen synthesis male sexual differentiation, and pubertal development. In females, it's also important. It's responsible for estradiol production, ovulation, and luteal formation. So it's important in both genders. And it has two phenotypes. The phenotype that I have in my patient, which is the 46XY, they would have Leydig cell hypoplasia, which is extremely rare, and it results in male disorders of sexual differentiation. So they will be raised as females. And the phenotype in female, it would result in either infertility, primary amenorrhea, anovulation, and other manifestations. So what happened to my patient? She was initially seen in family medicine clinic and referred to OB/GYN for further care. Then endocrinology team were involved. The impression was complete androgen insensitivity. Later, genetic workup showed LH-CGR mutation. The diagnosis was disclosed sensitively to the mother initially, and the family were asked to do the segregation analysis, and the sister, who's also affected, is currently following with endocrine as well. Family meeting will be arranged with both parents and a psychologist and a social worker to address the diagnosis. And she would need hormonal therapy for life. And also she would need surgical removal of the gonads due to the risk of gonadoblastoma and tumors. So my teaching points, we face a lot of challenges in these cases because we know we have now a biopsychosocial aspects and counseling. It's really difficult for patients to figure out that they have the opposite gender in the adolescent years, which is already, they face a lot of challenges in regards to puberty. Diagnosis may extend to other family members, and this is the case in my patients. So the sister was also affected. The rest of the family were carriers, which means they would need to know about the diagnosis and they need to marry someone who's not a carrier. And other relatives might be at risk. You can remember now the extended or the distant maternal cousin who had the same complaint. So should we talk about the diagnosis or not? And here comes the privacy versus the prevention rights. This is a systemic review of a similar case, and you can see that they included 88 patients. Most of them were XY and the rest were XX. And they reviewed all the patients. So let's take the patients who are similar to my case, who were raised as female. Their total number was 56. Very similar presentation, 15 years of age, delayed puberty, low testosterone. And most of these cases were actually raised as females, and they did not report any gender dysphoria later on. The rest of the presentation were 46XY who were raised as males. These usually presented at a very younger age with either ambiguous genitalia or atypical genitalia, and were raised as males, and they also did not report any gender dysphoria. My take-home message is we need to keep disorders of sex development in any patient who present with delayed puberty or primary amenorrhea, who are remarkably tall. And we also need to know that there will never be a perfect outcome for these patients. We try to give them the best possible chances of a freedom from illness. We need to approach these cases in a biopsychosocial model. We need to be very cautious in counseling, and a psychologist and a social worker definitely needs to be involved. Thank you very much, and here I conclude my presentation.
Thank you, doctor. That was a very interesting topic. Does anybody have any questions for Dr. Al-Harbi? We will continue on to our next speaker then, which is Dr. Swati Jagdish from India, who is a psychologist. Her presentation is titled How Early Boundaries Shape Adolescent Sexuality, Insights for Parents and Practitioners. Thank you, doctor.
Hello, everyone. Good morning, all the way from India. Wonderful seeing all of you today. Just sharing my slide. Is it visible?
It says you started screen sharing, but I don't see the slide. Oh, there we go. Perfect.
Okay. Yes. So first of all, thank you so much for inviting me to this wonderful conference. I was listening to the past couple of talks, and I got a lot of insights. Being into the field of sexuality health, we get to hear all these stories now and then, and we recommend them to practitioners such as you guys. And thank you so much for the service that you guys are doing for children as well as teenagers. Now, today I am presenting how early boundaries shape adolescent sexuality. So, there's not a lot of clinical information in today's presentation. It's all psychological, emotional, the angle of parenting, the angle of how schools impact children and child and teenage development. What I have been seeing in the last 14, 15 years of being in this field, all of that is what I'm sharing with you guys today. All right. So this is me. You can find me on social media. I'm what you call a conventional influencer, okay? Yeah. So this is what I do. Second, I have changed the slide, but it's not moving. So I'm just going to wait for a second. I think it's slow. Oh, okay. It went somewhere. Okay. All right. So when it comes to health, we are aware of physical health, emotional health, social health, psychological health, and we are also wonderful parents and responsible adults. I know some of you might not be parents, but still, I'm talking from the angle of a parent. I have a 11-year-old daughter. Okay, sorry. Yeah. So this slide got missed in between. So this is what we'll be going through today. 5 major concepts. Yes, getting back to health. So as responsible parents or as responsible adults, we are making sure that the next generation is aware of all kinds of health. But when it comes to sexual health, we somehow get stuck. We don't know where to start. We don't know what to teach them, what not to teach them, considering we are living in a digital overload of information these days. We are kind of scared. Oh my God, are they going to get some extra information? Are they going to freak out? All of that is there. So I got into the field of sexual health from my conventional psychology practice. I got into lactation. From lactation is how I got into sexuality. So I was a lactation consultant for many years. And then I was creating content on breastfeeding, postpartum, all of that. And somehow or the other, I organically just transitioned into talking about sexuality. Of course, it was a time when my daughter had also started asking uncomfortable questions. And we also have a huge community of parents in the city that I'm in. I'm in Coimbatore. It's in the southern part of India. And we have a huge parenting community. So we go to these community meetups and parents ask all these kind of questions. And that got me intrigued to learn about the subject. And that's how I got into sexuality health education. I do not take classes to kids and teenagers. My classes are all focused on parents, teachers, and other responsible adults who want to learn. All right, so the first point I want to make it very, very clear is that children who can communicate clearly about their bodies are safer from child sexual abuse. And there are these basic fundamental conversations that every parent or responsible adult or safe adult needs to have in their homes. So first things first, talking about private parts in an open, honest manner where there is no judgment or shame. Talking about private spaces, where is it okay to be naked? Where is it not okay to be naked? The concept of privacy, the concept of safe adults. Who are your safe adults? Let's say at 3, 4, 5, I used to have the conversation with my daughter and I used to tell her, mom, dad, grandpa, grandma. So we are in a joint family, grandpa and grandma is along with us. And then I also had to add her nanny into the safe adult conversation. I had to add her doctor into the safe adult conversation. And talk about safe and unsafe touch or behavior. So it's no longer good or bad. We are asking the child to connect with the body and ask the body what feels safe. So does it feel safe? Does the person's presence feel safe or unsafe? They needn't even touch. They can show something. They can, it can be a picture. It can be something on their phone. So it just needs to feel safe for them. So more than about where the touch is happening, because way beyond way before a touch can actually happen, there is something called grooming that can happen, wherein the potential abuser or predator can actually gain the trust of the child or the teenager. So for that, they go through something called grooming, and they might not even touch them during that time. So instead of focusing on the touch or the place where the touch happens, we ask parents, teachers, etc., to teach safe and unsafe, so that they are more in tune with their body and what they feel inside. Of course, this can vary between neurotypical children and other children. But yeah, this I usually focus on neurotypical children. So this is what we teach. And yes, not to have any secrets. Tell them that secrets do not keep you safe. So no secrets. We are a family that have open, honest conversations all the time, and all kinds of intimate discussions about the body or body fluids or body parts. It only happens with the parents. So this is another thing that we ask parents to talk about with children. Then we ask them to deal with consent and boundaries. Consent is just more about permission. No is a no, all of that. And boundaries, again, it's my favorite subject. My focused workshop on boundaries is around 5 hours of content, so it's my favorite topic out of all the sexuality health related topics. Yeah, talk about firm boundaries, and then of course about periods, both to boys and girls. And this is where a lot of parents ask questions about how deep should we go, what all should we speak about, what we should not talk about, etc. I make it very clear that it needn't be a clinical conversation that you need to have. Because I remember when my mom had the conversation with me, I think I was 8 or 9 years old, and she talked about, the cervix and uterus and some fallopian tube and whatever. And I didn't get anything. I didn't understand anything. In fact, I was more scared. Had she just told me that, you will find some blood stains and, just have to come and tell me it's all okay, that would have been enough. So we just need to take into consideration the age of the child, the articulation capacity of the child, because some children are really good at understanding, more when the parents explain, whereas some children just need some basic level of information. So it all depends on the personality of the child also. Yeah, so to talk about maybe period products, to talk about that there is no shame in going through periods, or even dada or even father knows about the mother going through this. So those kind of very open conversations are more than enough before getting into any clinical details, is what we tell parents. Yes, so it is the same information that is supposed to be given to boys and girls. And this is again a place where a lot of people ask, ma'am, you are okay to talk about all these things because you have a daughter. What if you had a son? And I just assure them that, what, if I had a son also, I would do the same thing. Yeah. So these are some of the questions I get on a daily basis into my DMs. I'm just going to read it out to you all because most of you are doctors, and I don't know, how far parents are opening up to you guys. But because me being in the mental health field and also dealing with sexuality health, these are the questions, some of the questions that I get to deal with. Why is my child always touching their private parts? How to handle it? Of course, we need to assure them a lot when it comes to self-soothing, self-gratification behaviors. What do I explain about periods to my 8-year-old boy who found my sanitary napkins? My 5-year-old is showing the middle finger ever since he's back from school. What do I do? I heard from my son's teachers that the 4th graders are saying the F word and other swear words. What do we do? Can we be naked in front of our children? Can we bathe with our children? My 6-year-old is very curious about my breast because I have been breastfeeding his baby brother. My daughter and her cousin were found exploring each other's bodies while playing together. How do we handle this? My 12-year-old saw some pornographic content on the phone. What do we do now? So just some questions, okay? These go in hundreds, by the way. These are just some questions. Yeah, so how do we answer these questions? Yeah, it takes a long time to explain little layers and nuances about the body and about how children understand the body, how curious they are. All of that is part of sexuality health sessions and workshops. But one thing I make sure I tell parents is, please don't panic for a lot of these things, because when they understand what is socially acceptable or appropriate, they just stop. For example, when did you stop going around in an underwear around the house? Because it is my safe space. My home is my safe space, so I feel okay to go around in an underwear or with less clothes. But then I don't do that. After a point of time, let's say after 7 or 8, I do grow some boundaries, right? I do develop some boundaries. Similarly, when did you stop biting your nails in public or digging your nose in public, right? So we all tend to stop certain behaviors at certain stages, and I just assure parents that, you know what, it's not going to continue for a long time. They are going to stop. And for the rest of the concepts that they want to talk about or know about, I lead them to my social media pages, my podcast. I have a wonderful podcast called Stories with Maya Zama. A lot of questions are already answered on that page. Otherwise, I ask them to attend workshops, or take one-on-one coaching, stuff like that. Yeah. One major point we discuss during sessions is to have two aspects when they have conversations with children, which is the aspect of talking about facts. Number two, talking about value systems. So, fact is just the scientific definition of something, which can be the same thing all over the world, that would match everybody's lives. But value systems are not like that. It changes from person to person, changes from community to community. And even for certain countries, they might follow a certain value system compared to another country. So value systems can change. It can be dependent on my upbringing, my childhood. So many things can be dependent on values. So for example, uh, periods. So when you talk about periods, we ask parents to talk about what it is, how it happens, how does the mother feel when she's on her period, how dad helps out, or what kind of products are used, those kind of things, and then gradually increase the number of information or points as the child grows and as they get curious. And also talk about your value systems when it comes to periods. So I come from India, and there are a lot of belief systems, even myths and superstitions that are followed in India. So we focus on that. For example, you know what? Grandma doesn't like um, Amma entering into the kitchen during periods. But you know what? There's nothing like that. I can go make a meal. Who else will cook for you? So if grandma comes over and if she shames me being on my period, you know what? You don't have to bother, because Amma's not going to bother, because we are trying to unlearn all of that, and those value systems are changing. Or for example, you can add on another value system that says, you know what, in our family, we don't shy away from these conversations with boys and men. Or we can have a value system that says, you know what, in our family during periods, we make sure we rest a lot. Anything can be added on to value systems also. So any concept on sexuality health, we ask parents to talk about the fact and also about the value. Now, one of the problems in having sexuality health education in schools is that an educator or a facilitator who takes over these classes will be able to provide only the fact. They won't be able to give a value system attached to it, because I can have 30 kids sitting in front of me and they all can follow different value systems in their families. Now, this is just a question to all of you. You don't have to answer it, but then you can feel free to answer in the chat box if you wish to. If you go back to your childhood, if it is not a traumatic memory, okay, if it is not a traumatic memory, if it's just a memory, I want you all to go back to those ages when you went through some form of unsafe behavior from an adult. It can be a known, respectable adult whom you never thought would do something, or it can be someone else. Considering, yes, boys also go through these things, most of you might have might have such experiences to go back to, right? So it might have happened in the age of 4, 5, 6, or 7. And if you want to share, I want you guys to share in the chat box. How did you know what happened was not okay? I would like to repeat it a bit. How did you know what happened was not okay? Because we were not educated on safe touch, unsafe touch, privacy, private parts, or good touch, bad touch, or any of these modern day concepts, right? We knew nothing. We knew nothing about consent, boundaries, body autonomy, nothing. Yet we all knew what happened was not okay. Fundamentally, somewhere inside us, we knew that. Now, I'm sure many might not be comfortable to share, so I'm just slowly getting into that response, which is your body would have communicated it to you through discomfort. So you felt uncomfortable, you felt unsafe, you felt dirty, you felt awkward, right? So it was more of a bodily response than a brain response. Your brain probably didn't tell you anything, or it told you, you know what, it's your uncle, right? Your uncle has always been sweet to you, right? Your uncle is sweet to every child in the family, right? So what? This is probably the way he's being sweet, right? So your brain would have given you something to, confuse you, I would say, but your body would have never confused you. Your body would have been clear from the get-go, right? Your body would always tell you what is okay and what is not okay. The body is constantly communicating with you. Yeah. So that way, I'm sure your body would have told you, oh, you know what? Get away from here. This is not okay. This feels uncomfortable. This feels awkward, right? So that gets us into this concept of body intelligence. There is an innate intelligence in all of our bodies that tells us what is okay, what is not okay for it. Okay. And we need to raise our children and our teenagers to be aware of this bodily communication or bodily intelligence. You need to be aware of what is going on inside your body. I'll give you a small example. I keep quoting this in my classes. My daughter was 5.5 years old, or maybe even 6. Once in an apartment complex when we were staying, she was going out to play with her friends, and it was month of December. And I told her name is Maya, by the way. And I told her, Maya, when you're going out, wear a sweater and go, baby. It's so cold. And you know what she told me? She told me, Amma, if you're feeling cold, you wear a sweater. I'm not feeling cold. So I just told her, you know what? The sweater is there on the sofa. You can come back anytime and just take it. So we need to be, reassuring our children that, you can listen to your body. Listen to your body. Okay. Yeah, so those who are interested can go read more about bodily intelligence. We call it the somatic intelligence. There are lots and lots of literature available. One of my favorite books written on this topic is Your Body is Your Brain. And there's another one, The Body Keeps the Score. Yes, so moving on, consent and boundaries. So we need to teach them to hug another child if after asking whether you can hug. And who needs to model it? We. So we are their model for consent as well as for safe boundaries. For example, if guests are coming home, they have a baby in their arms, are we just going and grabbing the baby from them, or taking a second time to ask, you know what, can I hold the baby? Those things they're watching, they're observing us all the time. So they are just watching and learning. So we need to model it all the time. And boundaries and consent is sort of like brother, sister. They're closely connected to each other. And we need to keep assuring our children that you are the boss of your body and you have the right to say no to any kind of uncomfortable touch or behavior. Okay. Keep on telling it, keep on telling it, keep on telling it in such a way that it just gets, gets into their hard drive. Yeah. Now, before talking about kids' boundaries, we need to also ask ourselves, do adults understand boundaries? Like I told you that example of hugging random children, picking random babies, maybe even in Indian culture, what generally adults tend to do out of love. Okay, I'm just reassuring you, there is no bad intention, but adults tend to pinch cheeks of children. It might be different ways of showing affection in your respective cultures and countries, but here it's super common to go pinch children's cheeks. And do we tell no? Do we tell no to other people? Because these are the things that our children and our teenagers are growing up and watching. Is my parent having boundaries? Do my parents have healthy boundaries? Do my parents say they are uncomfortable? Because they're watching, right? Let's say a relative comes home and then you're not too comfortable with them at all, and then you sit, you stand, you just, talk to them, laugh and everything, and the moment they're out of the house, you have a different kind of conversation. They're watching all of that, they're seeing all the hypocrisy. Okay, so yes, we need to model all these to them. And the American Academy of Pediatrics also, have mentioned at multiple, in multiple journals, how to have open conversations, how important it is to have these conversations to them, how parents and responsible adults need to talk about names and functions of sex organs, about pregnancy, because children are curious, when a child is 4, 5, 6, he or she has a parent that might be going through another pregnancy. So they will definitely have doubt and curiosity. My child does not have siblings, yet she was curious. Puberty and physical changes, menstrual cycles, gender issues, self-soothing behaviors, preventing pregnancy. And these days, sex educators have also added a couple of extra points into it. Parents' expectations and values when it comes to sexuality, health, sexual abuse, and how to prevent yourself from, sexual predators. These are all things that we need to talk to them by the age of 10, 11. Now, is it practical to go bombard them with all of this information at 10, 11? Not at all. They will get overwhelmed. They will get overloaded with information, and many of them can even get scared. So it's our duty, our responsibility to have conversations, minor conversations, mini conversations, simpler conversations when they are really young, and build on it as they grow. Coming back to somatic intelligence, what does the body communicate, or how does the body communicate? The body mainly has two ways of communications. Number one is physical sensations. I feel hot, cold. I feel comfortable, uncomfortable. I feel tingling sensations. I feel goosebumps. I feel prickly sensations. All these things are bodily sensations that I feel, physical sensations, and also emotions. These are all ways in which the body communicates. If a person is really aware of physical sensations and emotions, it means they are embodied. They know what's going on in their body. Yeah. Now, there's plenty of science that's coming up tapping bodily emotions. Where do these emotions originate from? Where are they existing inside the body? Can we measure where anger is? Can we measure where disgust is? Can we see where happiness is? Can we see where love, or grief or shame or betrayal, all these things, where is it in the body, right? So plenty of research that's coming out. Now, this is something that we need to be aware of when it comes to a child's development, because when a baby is born, like most of you are pediatricians, you know this, right? We keep the baby on the chest, we allow the baby to breast crawl, the baby just goes and finds the breast. So it has that orientation. The proprioception helps the baby to find where he or she is. And then the baby starts breastfeeding, and then the baby understands, okay, I'm a part of this body. Baby doesn't really know that the mother's body is a separate body, so there is no concept of bodily autonomy there. According to the baby, the mother is the baby's own body. That's why when the mother puts a baby on the bed and moves away, baby cries. That's because, hey, come on, my body, you're walking away from me, right? And then slowly it explores its own body, then it explores the environment. Then slowly is how we humans learn to separate ourselves from the primary caregiver and move away into the environment by crawling and moving away. Okay, fine, I'm separate. I'm a different person. And they understand and integrate that information by around age 4, and they start saying no, I'm not coming there. I'm not going there. I don't like it. And that panics parents a lot. What is this? Suddenly they are all, grown up. Right. So slowly is how we realize that we are separate beings. We have something called autonomy. And this is again a favorite, part of storytelling for me, how I go about training parents on baby-led weaning. And because I tried baby-led weaning with my daughter when she was 6 months old, and it was a huge success. Of course, it doesn't work for every baby, but majority of the babies, yes. In our community, we have around 50,000 plus parents who try these things out, and we take these classes, we explain to them how it's done, do's and don'ts, all of that. We also have pediatricians as part of our community. They talk about the clinical angle, we talk about the psychological angle, all of that happens. So this is another area where the child understands, yes, hand to mouth, or I can eat by myself, or I can handle it by myself, or I can make some mess and learn a lot about mess, because of course we know, right, messy play can help them learn a lot. They understand, oh, I'm full, okay, I can eat this much or this much, this is my capacity. And when I say no, somebody should be listening to it or respecting that no. So how do we teach children to say no when their no's are not respected? Because again, I'm telling you, I'm talking from an Indian perspective. In India, respecting children's no usually does not happen, because caregivers or care providers are hell-bent on just finishing whatever is there on the plate or the bowl. So parents, these days or nowadays, force feeding tactics are not so common. It's somehow just slowly vanishing, but distraction feeding is happening a lot. Distraction with stories, songs. I've seen grandparents dance and perform in front of grandchildren so that they eat and finish it off. And then of course screens, right? So gadgets, screens, TV, all of that is there. Taking the child to the park, going around, and making the child slowly eat. I remember in the apartment complex that I used to stay, there was a grandmom and a grandkid who used to come downstairs for breakfast. She will have 3 big idlis. Idli is a steamed rice cake. It's an Indian, breakfast meal. And she brings around 3 idlis, and she walks around the park and somehow tells him stories, and somehow makes him eat the whole thing dipped in cow's milk and sugar. And after, let's say she's done, she comes around by 8:39, she finishes by 10:30 or 11. She goes up, and then I again see her by 12:31 coming down for lunch. So children who grow up in these kind of situations, they don't know when they get full, they don't know satiety, they don't know to say no, because their no's are never respected, right? So imagine from 6 months, this violation of bodily boundaries happen. I know parents who bribe children to eat, threaten children to eat, beg children to eat. Somehow, please eat, otherwise grandma is going to scold Amma, please eat. All these things happen. Or maybe comparison also. Look at how your cousin is eating. Look at how the neighbor's kids are eating. All these things, right? So when my bodily boundaries are violated from the month from 6 months, or even let's say we are feeding the child from 6 months to 1 year, by 1 year they should be ideally capable to eat by themselves. So from 1, 2, 3, 4, 5, their boundaries are violated, and by 4, 5, 6 we are telling them, you know what, if your body is telling you no, just listen to it. They become very confused, because you know what, this has never happened in my life, I don't know how to do it, because you guys have never respected my boundaries, right? So meal times are a very important aspect of learning bodily autonomy. Boundaries, consent, everything comes into meal times itself. So I joke around in my sex ed class telling, you know what, sex ed starts at 6 months. That's actually one of the main themes of my TEDx talk also. You can find it out on YouTube, how I explain this whole concept in a very detailed manner. And then, yes, they get into toddlerhood. Now, do they enjoy all these things, performing their songs and dances in front of guests? Again, I'm not sure if you guys are used to these things, but in India, culturally, we are used to performing in front of guests. We make our children perform something. Kissing, pinching of cheeks, wearing clothes that they're not comfortable in. Are children really comfortable to stand in a line? Are they comfortable to be quiet in a class? Are they made to do that? Are they developmentally okay to do that? Again, there are so many differences between boys and girls also here. What about if they are seeing toxic relationships at home? How does that impact them? So if the child itself is in a fight flight freeze mode if they are going through chronic stress or let's say trauma because of toxic family members or toxic parents. How do they integrate consent and boundaries into their life, right? They're super scared. They don't know how to react and respond. And yes, last but not least, have they gone through sexual abuse? Have they gone through trauma? Because trauma, what it does is it disconnects the mind and the body. So the brain and body starts working differently if there is trauma. So yeah, stress response also is very directly linked to the ability to draw boundaries. So is a child comfortable or is a child in chronic stress? So let's go back into our childhood, or let's think on behalf of our children. Let's say when bullying happened, why couldn't we react or respond? Why did we freeze? Why did we run away? When comparison happened between our own siblings or cousins, why didn't we express our discomfort to adults? When body shaming happened, why did we endure it? When we couldn't pee between classes, because that's one of the natural bodily urges that we feel, right? I want to drink water or I want to pee or poo, but I can't, right? There's a designated time when I need to do that. So we have grown up not listening to our bodies, and suddenly at the age of 14, 15, 16, we have to have boundaries and we have to have bodily autonomy. We have to know what we want. We have to tell no. It's so hard. It's so difficult. Now, how did we become these people who can't say no? So this is just my theory. My body would have wanted something. The brain or society would have said something else. This is an institution, you should behave like this. Or this is how this family member will behave with you. You have to be like this. You have to endure. You have to tolerate. You have to just sit there. You shouldn't respond. You shouldn't react. So body wanted something. Brain or society would have asked us to do something else. And we just followed. As a result, we have grown and evolved into people who can't say no. Now, there are a couple of factors that we need to take into consideration. Did we get to listen to our body? Of course, patriarchy plays a huge role where women would probably have evolved into people who couldn't establish better boundaries. Okay. Thank you. Excuse me. Yeah. And so there can be a gender related difference also, compared to men. And I'm not telling you men's boundaries are all amazing, because I have also men in my healing community and they are struggling with boundaries with their bosses, with their customers, with their clients, with their own mothers. All these things we are seeing. I'm not telling you it's wonderful and great for men, but women, we have gone through another whole different layer of lack of boundaries. And age is also a factor, right? Do we really consider the boundaries of a 6-year-old compared to a 26-year-old? No, children are not given bodily autonomy, right? So these are a couple of factors that we need to take into consideration. So by this point, yes, children, teenagers are at a disadvantage when it comes to bodily boundaries. So how will boundary work? Boundary will work only if we can listen to our body. We need to be aware of what our body is trying to tell us. How is it showing discomfort, awkwardness, heavy feeling, heavy heart, lump in the throat, funny feeling the tummy? All these things are the ways that body will, show you that, what, I'm not okay with this, or get away from here. These people are not nice people. Or, when this person starts talking itself, you feel a lump in your throat, look into it, look into it, look into it, listen to me, listen to me, listen to me. This keeps on going. But are we aware of those bodily communication? So I have just listed out some bodily sensations. This is from one of my favorite pages called Trauma Informed. Where do you feel smooth feelings? Where do you feel wet feelings? Where do you feel full feelings? Where do you feel fragile feelings? Where do you feel hot feelings or dark feelings or painful feelings? Are we aware of all these feelings are arising, where it is arising from? So this is again a beautiful example that I wish to quote. Imagine you are sitting in a concert. It's really loud. Your friend is trying to tell you something. You really can't hear because they are screaming and then there's noise. So you're like, what, right? You keep doing this. Now imagine if I transport you and your friend Matrix style into a library and your friend continues to talk that way. At that time, it becomes loud, right? That's because the library is quiet. So this is an example that is used to explain the concept of embodiment. Even now, our bodies are trying to tell us a lot of things, but we are unable to listen to it because we are sitting in this concert. Yeah, there's a lot of noise. That doesn't mean the body is not communicating a lot of things. It is communicating. Compared to when you heal or when you calm down or when you stop hustle mode or when you're not in your fight, flight, freeze, traumatized mode, that's when you actually get to listen to what your body wants to tell you. Which means there's a very popular quote that's used in somatic circles, which is your body is telling you something, but it feels like a whisper. The moment you tap into the body, you will realize that the body has been screaming all the while. So
Dr. Jagdish, we're
yes.
into another speaker's time. How many more slides do you have?
This is closing.
Okay.
So we need to focus on creating embodied children and teenagers for a healthy society. So this is something that we can focus on, enabling our children to listen to their bodies. So yes, children have gone through a lot of issues because of which their boundaries are not that great. But look at the second part of the image. Adults are also unaware of these things. Adults are also disconnected from their bodily signals. So something that we can do as healthy adults is to be aware of our own energy levels. Are we in balance? Are we in burnout? Because a lot of adults, they are in their hyper masculine, hyper independent hustle mode, and they are not able to rest and relax even. So as children and teenagers, what are they seeing around their house? As parents, are we restful? Do we know how to relax? Do we know how to get into the flow mode in life? Because from that only they will understand how to handle anger, how to handle irritation, how to handle overwork, how to not get into burnout, etc. So again, the AAP recommends pediatricians provide sex education to patients. So doctors should definitely deep dive into this subject, the psychological angle of this subject, because it's not always clinical. So I would recommend you guys to read up more on this. And I would say if sex education is hard to comprehend or understand, we can even reframe it into something like relationships and emotional education, because of which we can create more awareness. So ask yourself, what about your boundaries? Do you understand gentle parenting principles? What is your anger management like? How is your body confidence like? How much of self-esteem do you have as adults? Are you going through relationship issues? Are you a people pleaser? Do you have past trauma stored in your body? Are you aware of your own sexuality health? So I think adults can ask these questions and also nourish themselves. I see a lot of parents, teachers, or even responsible adults pouring out into other people, but they are not nourishing themselves. So this image is symbolic of that. Yes, you please pour out the juice that's inside you, but remember there is a lid on top of that bottle. You have to pour into yourself, nourish yourself. So this is my message to you guys for this talk. Adults should go through their inner work so that they get better at managing relationships, their energy, work, and parenting, so that they become inspiring humans to their children, so that their kids and teenagers can just watch and learn from them. We'll not have to have any specific boundary class for them if we just model it to them. Yeah, you can follow my work on Instagram as well as on YouTube. I go by the name Maya's Amma. Thank you so much for being such wonderful participants.
Thank you for the presentation. We need to go right into Dr. Mina Khans from Iraq, a medical student and marketing coach at Labor Union. Her presentation is the impact of energy drinks and excessive caffeine consumption on high school students, effects on the nervous system, and overall health. And just remember, it's a 20-minute time slot. Thank you, Dr. Khan.
Good morning, everyone. I hope everyone is doing well. So first of all, let me introduce myself. I'm Dr. Mina Khan from Iraq. I'm a medical student and also I'm a businesswoman, content creator, and a marketing trainer. I'm really glad for you to have me here today in your conference, and I really wish that I could be with you in person, but unfortunately I couldn't make it to Dubai because of the visa issues, as you know. But today we're gonna talk about something really, really important, especially nowadays, because nowadays, as you know, social media is like have an effect on everyone and on everything. And being caffeine consumption heavily, unfortunately, is being taught as a good trend, because everyone is having their iced coffee every morning before school, before going to college, and all of these things, as you know. So today we're going to discuss the impact of energy drinks and excessive caffeine on high school students, and even on everyone, actually, not only for teenagers, but as you know, teenagers are more sensitive and they are in their growth phase. So we have to be careful with them. So for understanding the effect on the nervous system, because as you know, they take caffeine to be more focused and to give them more energy. So it is mainly affect the CNS or the brain and overall the health of the body. So as a high school student face increasing academic stress, many turn to energy drinks and excessive caffeine consumption so they can quickly fix their alertness and focus. So this presentation will explore about these things. Let's start with you guys. I know many of us are having caffeine like pills or like coffee daily or even energy drinks weekly. Actually, for me, I've been in this situation years before, and I really, really got some bad health issues until I got to hospital because of these things. And finally, I cut them off because they were really harmful for my body. So if you are taking them on a daily basis, you have to recover this thing and rememorize it. So why this topic matters nowadays, especially this statistic around teenagers' caffeine are alarming and continue to rise each generation. Just imagine, each generation are consuming more caffeine than the last one. So as you can see here, 30 to 50% they are taking energy drinks, and more than 122% they are taking caffeine. So this is really a bad prognosis for teenagers' health in the future, not just only for now. So nearly half of all teenagers regularly consume energy drinks, with numbers increasing during exam periods, especially. And increasing caffeine intake with age, they are more double from middle school to senior year as academic stress they are having. The concerning effect of these things is, as I told you, is especially on the brain and the central nervous system, and it's already having secondary issues like disturbing sleep, like impaired attention, like significant mood alteration, and we can discuss this more ongoing in the presentation. So how caffeine works on your body. As you know, the caffeine is a powerful central nervous system stimulant. So it blocks adenosine receptor, preventing drowsiness and increased catecholamine. So it is raising the heart rate and the pressure rate. Delays sleep onset and reduce sleep quality. As you know, how much sleep is a really important thing. It is important as much as the respiration. Can you imagine that when we sleep, we can have the most benefit of sleeping for our brains. And also it creates a synergetic effect when combined with sugar. So they can get caffeine from tea and others, and energy drinks, and even soda like Coke, Pepsi, and Fanta, or even these things, they have much caffeine, and also coffee. So these things are having two bad things. It has an acute effect on your body, like instantly, and it has a long term, or as we say, chronic effect. For the acute effect, it is within an hour or within hours from drinking the caffeinated drinks. increasing alertness and energy. This thing is positively impacted for those who are consuming them. And jitteriness and restlessness, rapid heart rate, it causes tachycardia. I think you all experience that, because when we drink high caffeinated drinks, we all, like when we climb a ladder or walk just a short bit, we can have tachycardia like never before. And also anxiety, irritability, and gastrointestinal discomfort, and sleep disturbance. And for the chronic effect, for weeks, on even months, and even years, it's impaired attention and focus. So, like, you will be addicted. You cannot focus, you cannot study, you cannot work unless you have your coffee today, as it is going nowadays. So, this is really bad thing. It is addiction. Reduce memory consolidation, because as you know, the memory consolidation, it transfers from short memory to long memory term in the brain during sleep. So as you have a sleep alertness or a sleep impairment, the brain cannot process the memorizing things. So your memory will be really bad because of high caffeinated drinks, especially if you are detected to it. And also elevated blood pressure, increased metabolic risk factors, tolerance, requiring higher doses, and withdrawal symptoms when stopping. So, for the students most at risk, or who are really at risk of these things, first of all, the age factor is really important. People under 16 years old, they are having cardiovascular issues, they are having sleep issues, they are having anxiety, and even depression rate is increasing with the generation because of these new trends, unfortunately. So they already advise us to not drink energy drinks or high caffeinated drinks under the age of 16. And for the second one, if you have any pre-existing conditions, like those who have anxiety disorders, sleep disorder, they already have cardiovascular issues, and they are now consuming caffeinated drinks, it is really, really bad, and you have to stop that. Or tell your teenagers, if you have kids, if you are in touch with such people in these ages, you have to advise them and show them what is the harm of these things. They already see how it really benefits them through the day, but they cannot tolerate it for a long term. They cannot tolerate it in their thinking as the first thing. But when we can give them the knowledge how this can affect them, how this can affect their bodies, maybe they will stop it, or at least don't be addicted to it like nowadays. For the third thing is high consumption pattern. Student consuming more than 100 to 200 milligram of caffeine daily, like roughly 1 to 2 energy drinks, enter a high risk category for adverse effect. And I think we all know some people who are drinking 3 times a coffee in one day or more, maybe. And for the medication interactions, if you are taking a medicine or supplements, or already have sleep deprivant and exam stress, they have more medical issues. So, global and national recommendations about these things. The American Academy of Pediatrics advised us to avoid energy drinks entirely, like we cannot even use them under the age of 18. No safe level established for children and adolescents. And for the European Food Safety Authority, maximum is 3 milligram kg per day caffeine for adolescents, like roughly 200 milligram for average teen. And for the Health Canada, maximum 2.5 milligram per kg per dose, with comprehensive labeling requirements for all caffeinated products, as you have to read the label before you consume these things. So, what are the healthy alternatives, and how can we support the people who are addicted to caffeine. How can we give them alternative to use it instead of this? First of all, it is a smart hydration, because when the body stays hydrated, it functions more efficiently. So water and natural flavored beverages provide sustainable energy without crashes, because the most crisis we have in energy drinks and caffeine beverages is that the body has a crash in some time, and dehydration mimics fatigue. And the second thing is sleep hygiene. As I mentioned earlier, the sleep is really important thing. It is important just like respiration for the human being. So when we sleep, the memory is being resolved, the brain is getting his rest, and everything that is going through our day is being processed when we are sleeping. So, constant sleeping from 7 to 9 hours for adults, and even from 9 to 10 hours for teenagers, it improves the memory consolidation, attention, and even mood more effectively than any stimulants. And trust me, if you are a regular sleeper and you sleep good quality and good time, you can see that on your mood, on your smile, and even on your energy through the day, as I experienced that, because before years I was having the prevention of sleeping, and I wasn't asleep at all almost. And the third thing is the nutritional focus. So let's be real. The food is more curable than anything that we can even have from outside. The God creates food for us to give us all the advantages we can have. So when we can take B complex vitamin from eggs, leafy greens, nuts, whole grains, it really naturally supports the energy sustained level and help us to make the memory more efficient. And for the education program, for school policies, and also for study strategies. And there is a thing that I really make it an alternative for myself, rather than relying on high sugar and high caffeinated energy beverages. We propose utilizing natural guarana seed extract. And if you don't know what is the guarana, it is a botanical source that is having healthy caffeine. It grows only in Amazon forest, and it slows and sustain the energy release. So it cannot make crash and energy suddenly in the body, which efficiently support both conjunctive focus and also physical endurance without associated crash. This is the key component of Lyft products that I use instead of drinking any caffeinated beverages or energy drinks. So every day, like almost when I have tough days like today, I get my Lyft shot right before the conference. And now I'm going to my college, and then I have another conference here in Iraq. So I have a long day. So I took my Lyft for today. It's gonna keep me focused and energetic all of the day, but with no harmful effects, as we said before, and reasonable energy rate. And for consolation and your call to action, the science is clear. While caffeine can provide temporary alternate, the risk to developing teenager brain and bodies often outweigh the benefits. So it is not gonna benefit you as long as they gonna harm you so much, especially the energy drinks and excessive consumption. So, risk to remember, and this is my last thing, as I can say, that your sleep is being disturbing, affects your next day performance, and it is an accumulating effect. So, every day is gonna be not as much as you expect and not gonna be good. So, it will harm you on a long term. And also increased anxiety and mood swings, cardiovascular problems and stress, and elevated blood pressure, impaired memory and attention over time, and also potential for dependence on tolerance. And for the healthy alternative, we can regular our sleep, we can stay hydrated, we can focus on nutrition rich foods for sustaining energy and using them to boost our memory, and also study breaks and how we can manage our studying and physical activity for natural energy. And if you have any questions, you can ask me because I finished my session, and I really hope you enjoyed it and you have some attention for how much they are harming us, and it is not a good trend at all. So now I can give the mic back to the host, and thank you so much for having me here today.
Thank you, Dr. Khan. That was a very great presentation. I loved all the animation. Are there any quick questions? All right, we will continue on. Our next speaker is Dr. Fatima Azam Shaheen from Jordan. She's an ophthalmologist, and her presentation will be Little Eyes, Big Decisions, When to Refer to an Ophthalmologist. Welcome, doctor.
Hi, good morning. Can you hear me?
Yes, we can hear you.
Okay, I want to share my presentation. Can you see my screen?
Not yet.
Okay. Okay. Now you should see it.
Yes.
Okay, let me put it up. Okay. Okay, so good morning, everyone. I'm Dr. Fatima from Jordan. Today, I'm gonna speak about when to refer to an ophthalmologist, as this is because you guys, pediatricians, you are the first people to see kids, and by this way, we should be able to help more kids to prevent further problems with preventable problems, mainly amblyopia and life-saving problems, just like retinoblastoma and other stuff like this. To start with, we all know that children don't always tell when they have problems. They don't know what's a 6/6 vision. They think what they see is the best vision. They don't know better. So area recognition is actually your role to diagnose the kids and refer them at the proper timing, because 80% of the learning depends on the first 7 years of life. And main conditions are always silent at first. To start with, we should know what's normal to know where is the red flags. For newborns, it's important to track the light and see, they don't see well, but they can track light. So if you don't have absent red reflex or even white red reflex, that's a red flag and should be referred immediately, urgently. 2 to 4, they start to follow faces and actually recognize people they know very well, like mom or dad. If they have persistent nystagmus, which is the eye moving very fast, they should be referred. From 6 to 12 months, they know depth, they can see more clearly, more details. If they have any sort of squint, they should be referred because this will affect the vision and needs to be corrected proper timing. 2+, they'd be like normal kids. They know how to see stuff, diagnose, differentiate. Any delayed response, they should be referred not only to ophthalmology, to other stuff to be exclude any important or red flags in their well-being. To start with, this first picture is a normal reflex. You can see both light coming from the retina, both red reflex, which is the right, this one, which is the red light coming from back. If we have just like this one, we have an absent reflex. That means we have a scarring or a problem preventing light to go inside. It's not a reflex from the retina. We might have corneal problem or congenital cataracts. This one, the red reflex abnormal. When we see the white reflex, that means there's something reflecting from the retina. The normal reflex should be red. If we have any other color, mainly white, this is a life-saving from retinoblastoma mainly. They should be referred urgently, the fast as possible, same day preferred. So I started with this one, which is the retinoblastoma, the white reflex. This is very urgent, needs to be referred ASAP. To go for toddlers, if we have squint, this will prevent the double vision, the vision from both eyes. This will prevent depth perception and will have really problem, needs to be sorted very quickly. Lack of eye contact is also very important. It might be to eye problem, refraction problem, or it be like a cognitive problem, but ophthalmology stuff needs to be excluded first. When we get to school age, if the child wants to sit next to the screen, or he has like headaches, squinting, or constant eye rubbing, these kids need to be seen with ophthalmologists because they may have like simple stuff. Allergy is with the eye rubbings. They may have like high IOP, or maybe refractive error that can be corrected very easily. So this is a message for you all guys. When you are in doubt, always refer, because it's better to be like, refer too much than refer too little. Don't Google, just refer. Okay, so the big five not to miss. Amblyopia, because it's a preventable blindness. Like yesterday I had at my clinic, a girl, she's 10 years old. She's in a very good school in Jordan. Her parents are very caring, but she never says she complains. She's okay, she's very good at school, but she never went to an ophthalmology, and suddenly she came to us with like a -3 myopia and severe problems, and with some sort of amblyopia which could be prevented 5-6 years ago. Kids don't complain, they just adapt. Strabismus, if you have the two eyes not centered as well, one is going to the right, one is going to the left, this to be seen by ophthalmologist. Be aware, like myopia is coming really more in this current world, because and it's predicted that in 2050, 50% of the kids will have myopia, like 1 from every 2. So myopia, we should be aware of screen time. We should always encourage the parents to go like 2 hours daily and play outside, and not to sit in front of the screen for more an hour. Congenital cataracts, we have an abnormal cornea. We should like large cornea. The normal cornea will be from 11 to 12 horizontally. If it's more like this, we should be wide from both sides. If it's more, we should refer to an ophthalmologist. Retinoblastoma, I already said about this. White reflex is urgently should be referred to an ophthalmologist. I'm gonna start with some cases. If you have like a 2 years old with persistent watery eyes, the 2 main complaints will be nasolacrimal duct obstruction or glaucoma. We should always refer for both of these. Nasolacrimal duct obstruction is more likely in such case in a 2 years old. Glaucoma would come like in an earlier age with large cornea, and this is urgent. The child loses the eye very fast and it needs treatment. Nasolacrimal duct obstructions makes more sense because the baby might have like a sinusitis problem leading to this closed duct in the eye and needs to be referred to be treated. The next case, a 5-year-old one closes one eye by chance and it's like a window closed, he never sees. That's amblyopia. That's a problem a long time ago, and the patient is not diagnosed because he wasn't referred to an ophthalmologist early on. Because if a child sees from one eye, the other eye will not see, and the brain will block this eye, and you'll end up not seeing with one eye, just seeing with one eye, and it gets diagnosed by coincidence. But if the child goes to an ophthalmology early or be screened at a pediatrics clinic, I suggest each pediatrician to get this screening device, autoref, pediatric autoref. It's very easy to use and it doesn't need to touch the eye. You can check if they have like a rough decision, if they have like a severe myopia or hypermetropia, it should be referred to an ophthalmologist to prevent this amblyopia and later on. And the most important case, the one on the right, is a white reflex. It's completely abnormal. This child needs to be seen urgently, and it's life-saving, not just sight-saving, it's a life-saving problem. Okay, so as a pediatrician, I suggest that your role is like to document and follow up with the patients. Our role as ophthalmologists is like diagnose, treat, and rehabilitate both family and the child to help them. So together we share the goal to a healthy seeing child living a normal life from now on. And that's the end of my presentation. If you have any question, I'm happy to help you. Thank you.
Thank you, Dr. Shahin. Does anybody have any questions? We are making up some time then. Thank you. That was very informative.
I
Our
hope this
next-
like helps one child at least, because our aim is to help all children all over the world.
Excellent. I work on the NICU and we have a doctor that checks for ROP weekly.
That's amazing. ROP is a major, because the thing is, ROP is you know this disease is coming, so because they are premature, so they get diagnosed. It's very rarely that child get missed if he's premature. The younger, healthier kids, the older, healthier kids are the ones that's gonna be missed.
Yes, that's true. Thank you so much.
Yeah, thank you.
Our
See you
next-
later. I need to run to my clinic now.
Oh,
Good luck with the rest of
sounds
the conference. I was very happy to be with you guys. Thank you.
Thank you. Our next speaker is Mrs. Zainab Mohammed Defray from Lebanon, final year medical student, and her presentation is on Teach, Love, Inspire, Building Holistic Learning Environments for Children and Adolescents. Is Mrs. Defray present? All right, if we will just keep moving down the line then, which will also help us get back on schedule. We have Dr. Aygun, I'm not going to say this right at all, Musayeva, a pediatric endocrinologist with a presentation on when need to treat precocious puberty, new methods at treatment. Are you ready to present and share? Oh, wonderful. Hello.
Hello, everyone. Yes, I'm here. I will share my screen right now. Is my presentation, everyone seeing is my presentation right now?
Yes, we see it. Thank you.
Okay. I'm Dr. Aygün Sayava, and I'm happy to join with you today virtually. So before we are diving into the precocious puberty, I wanna touch about the normal range of the precocious puberty. For girls, the normal onset of puberty is happening between 8 and 13 years, and for boys, it's between 9 and 14 years. And we're assessing the puberty in girls and boys through the Tanner staging system. The Tanner stage 1 is a pre-adolescent for both girls and boys. At the stage 2, the first signs of puberty we are seeing, it's breast budding for girls and testis volume, the growth of testis volume for the boys. When it reaches to the 4 milliliter or above, for the boys, it's the first sign that puberty is start. And through the from the stage 2 to the 5, we are seeing the progress of the puberty. Spermarchy in the boys is the equivalent the menarche of the girls, which the average age of the
onset of spermarchy is around 13 years. But unlike menarche, spermarchy isn't a remarkable sign of the onset of puberty, because spermarchy can occur in early, before the start of puberty, or it can be absent until the last stage of the puberty. That's why spermarchy isn't a good sign to use for the sign of start of puberty. Our main goal in the precocious puberty treatment is to protect the adult age. That's why we have to know that the growth spurt time in puberty. For girls, it's happening earlier, between tender stage 2 and 3, which is around 9, 10 and 11 years. But for boys, it's happening later, between tender stage 3 and 4, which is approximately between 13 and 14 years. And when it comes to precocious puberty, the classification is that, like, precocious puberty divides between 3 main categories: central true puberty, peripheric pseudo, and normal variants. Central true puberty itself divides into 3 forms: organic, idiopathic, and genetic. Genetic one is the newly categorized one. It's newly started studying. Idiopathic one is the one far more common we are seeing in the girls, and mostly in the girls that age above 6 years and above, we see the idiopathic precocious puberty in them. And organic puberty is the most dangerous one and needs urgent attention and treatment, because of the underlying conditions like hamartomas, different neoplasias, and infections. And normal variants of puberty is premature telarchy, adrenarchy, and menarchy. Premature telarchy is equivalent to a mini puberty, starting at the newborn, and may delay until the age of 3 or 4 years. Central precocious puberty is like it's mirroring a normal puberty. It's generally starting from the central system, like normally in normal girls and boys, genes like MKRN3, delay KIN1, and KISS1 genes makes a break on the puberty. But when they have mutations, one of the genes have mutation, this break is released too early and causing a cascade of signaling increase, like the level of dyspeptin and neurokinin B and dynorphin neuropeptide level are increasing, causing the release of gonadotropin releasing hormone, which it leads to luteinizing and follicle stimulating hormones increase from the pituitary gland, and eventually it leads to estrogen and testosterone levels increase in ovaries and testes. Peripheric precocious puberty, in the peripheric precocious puberty, we don't see elevated follicle stimulating hormone and luteinizing hormone. They are generally in the prepubertal levels. The main cause of peripheric precocious puberty are adrenals and gonadal tumors, congenital adrenal hyperplasia, or McCune-Albright syndromes. Epidemiology of precocious puberty varies worldwide. In the studies taken worldwide between 1970 and sorry. Okay,
Somebody's audio's on that needs to turn it off.
Okay, the studies taken between 1977 and 2013, the mean age of breast development onset advanced 3 months per decade. It means that the development of breast budding started 3 months earlier per decades. And in the recent study taken in Istanbul in Turkey, which it covers COVID pandemic also, it shows that the age of menarche has decreased by 6 months over the last 12 years, which it shows that the COVID pandemics had effect to the precocious puberty. Risk factors that leading to precocious puberty are varies differently, like from the nutritional factors like vitamin D deficiency, overconsumption of processed meat, snacks, and fried foods, poultry products, especially chickens, out-of-season fruits and vegetables, also exposure to cigarette smoke, passive smokers, obesity with BMI over 95% percentile, and sleeping under the light, direct under the light, more than sleeping at late night, which all found a contribution causing to precocious puberty. As we mentioned that our main goal in the precocious puberty treatment is that protect the adult age, but there are studies that showing another long-term complications of precocious puberty we can see in untreated women, which in untreated central precocious puberty may increase the risk of premature coronary artery disease 1.37 times than who treated in childhood times, especially the ones that start treatment before the age 7. DLK1 gene mutations found connected with the increased risk of dyslipidemia, BMI, and insulin resistance risk in the late life times. That's why the one girls that who have DLK1 gene mutation, they especially need to start treatment as soon as possible. So let me illustrate the case presentation. The girl, 7 years and 2 months old, visited us at the clinic with breast stage 3 and pubic hair stage 2 and axillary positive. Her height was 125 at the first visit. It was actually normal for her age. It was between 50 and 75%. But when we compare it with her parents' height, which it looks advanced than her parents. That's why we had to check her bone age and do another test. She also had her initial test with her pediatrician 6 months ago. She visited us. We checked her those initial tests that she had luteinizing hormone at the pubertal stage already, which basal LH 0.35 is already mentioning puberty started, and her bone age that time was advanced. But when we rechecked her bone age again, it was already advanced to the 10 years. Her predicted adult height was 1.45 centimeters, and her ovaries already in 6 months period progressed to the pubertal sizes. We did stimulation test for this girl this time, and her peak LH levels was above 5 and 7. General in recent studies show that basal LH 0.3 and above has specificity 100% for the precocious puberty. That means that we don't need to repeat the stimulation test. But again, we did stimulation test, and stimulation test also confirms that she has precocious puberty. Why I mentioned that? Because if we didn't check her parents' height, her own height was actually in between normal range, like 50 and 75 around. But as her parents has short height, around 3%. That's why her height is advanced, and her bone age also showed this advance in her height. So if we didn't start treatment, she would have the short height more than her parents. In 6 months, after the 6 months of treatment, we managed that her bone age delay. So after 6 months, her bone age rechecked again, and it was 10 years and 3 months, not progressed another a year above forward. But we are still concerning to start growth hormone to her treatment, because the bone age advanced 8 years and above, adding growth hormone to treatment, it has beneficial effects for the adult age. So what message we have to take from this presentation is that if the child's puberty has progression of her stage of puberty 3 to 6 months, and if they have neurological symptoms, and if we see any precocious puberty in boys, and if the family have any endocrine disorders, especially precocious puberty in the family, like any grandparents or aunts have early menarche and even mother, or if the child has 2 years and above advanced bone age and growth acceleration approximately 4 centimeters in 6 months, we have to start treatment. And if we start treatment before the bone age reaches to 8 years, we may protect for adult age better. But it doesn't mean that we don't have to start treatment after bone age advanced to 8 years and above, because always treatment is better than no treatment. And at the end of my presentation, I want to touch current current updates in the treatment of precocious puberty. There are promising treatments that once yearly triptorelin, it's still on the ongoing 3-phase trials, which it will reduce the number of injections children for their treatment of precocious puberty. And we are currently using monthly or 3-monthly depots in our country, but 6-month depot versions are also in the use in many countries. So there are studies that compare the effectiveness and side effects complications of 3 versions, and there are no complications amongst them. All 3 of them have equal benefits for the treatment, and starting growth hormone with gonadotropin releasing hormone antagonists have better outcomes for the height predictions in the later times, especially the ones have advanced bone age at the initial visits. So there are also oral gonadotropin releasing hormone antagonists and cis-15 antagonists, which still there are no trial in pediatric patients, but they have effectiveness in the adult patients. If they will start to use in the pediatric patient, and if there will be any research and trials started in pediatric patients in the near future, it will be the better for families, especially reducing and replacing injections with oral versions, or cis-15 had promising effects that it will totally reduce all the yearly injections with just one injection at the start of the diagnosis. That's why they are still promising, and if they all will be confirmed, the effectiveness in the precocious puberty, it will achieve the main. It will have the best benefits for the children and families, especially in cost effectiveness and reducing the number of injections. And for peripheral precocious puberty, which is mostly seen as Marfan-Albright syndrome, we are using aromatase inhibitors, fulvestrant and letrozole. Still in the recent research, both are most used ones, but among them, letrozole are shown most effective as slowing bone age better and improving predicted adult age better than fulvestrant. So it's the end of my presentation. Thank you for everyone listening to my presentation, and I'm open to all the discussions and questions.
Thank you, Doctor. Are there any questions? Very detailed information for us. If there's no questions, we will move on to our next speaker. We have Dr. Sahsan Mansour from Libya, an Arab board-certified pediatrician and specialist in neonatal intensive care. Her presentation will be Growing Stronger, Evaluating the Impact of Art on Growth in Libyan HIV-Infected Children. We can see your presentation and welcome. Thank you for being here.
What? The screen is clear.
Yes, perfect.
Thank you. Well, good morning, distinguished guest, estimated speakers, and dear colleagues. It's a great honor to stand before you today. I would like to express my sincere gratitude, to my colleagues at Tripoli University Hospital. Also, I would like to express my sincere appreciations and heartful, gratitudes to organizing committee and conference management team for their outstanding efforts, their kindness, and exceptional communications through WhatsApp and LinkedIn. Thank you so much for your efforts, remarkable organizations, and your inspiring approach. Thank you so much. Well, my name is Dr. Sausan Nouri Mansour. I'm a neonatal care specialist, assistant lecturers, Faculty of Medicine, University of Tripoli, Libya, currently enrolled in a fellowship in neonatal intensive care. Well, I will give first of all overview about the human immune deficiency virus. HIV, as we know, is a retrovirus, and it usually primarily targets CD4 T lymphocytes, which are crucial for immune system functions. Transmission route, as we know, usually it's transmitted through contact with certain body fluids from a person who has HIV, including blood, semen, vaginal fluids, rectal fluids, and breast milk. It's not spread through casual contacts, alhamdulillah. About the replications, Bismillah. About the replications mechanism, as we know, it's on entering host cells, and after that, this HIV virus will use a reverse transcriptase to convert its RNA into DNA. After that, this viral DNA integrates into the host genomes and produce new viral particles. Well, about the clinical progressions, without treatment, the HIV, my colleagues, can lead to acquired immune deficiency syndrome, AIDS, as we know, characterized by severely weakened immune systems and increased susceptibility to opportunistic infections and certain cancer. Well, globally, as we see here in our slide, that 1.8 million children less than 15 years living, unfortunately, with this HIV. There's a significant increase of HIV cases in the general populations. The studies, unfortunately, are very limited in some areas, including our country. Libya data are scarce, but recent studies show concerning trends in the prevalence of HIV. No pediatric specific publications are found from Libya. Well, about the HIV and the growth. The HIV significantly impacts physical growth and development, especially in children and adolescents. The growth impairment manifests as stunting, wasting, and underweight. The stunting, as we know, it's a low height for age. And wasting is a low weight for height. Underweight, that means low weight for age. Perinatally infected children, those infected during the pregnancy, delivery, or breastfeeding, are at a particularly high risk. That's why. This is because they experience lifelong exposure to the viruses and the chronic inflammations, both of which contribute to long-term growth deficit and, unfortunately, developmental delay. As we can see, accompanying of this image, the effects are not just numbers in our study. They represent a real children who got potentially and healthcare deeply impacted by this HIV? Well, if you see the slide, we found that ART, that means antiretroviral therapy, impact growth recovery in HIV-infected children. Once the ART, subhanAllah, initiated, we note it's a significant improvement in both weight and height parameter, especially during the first year of treatment. Period now for maximal growth recovery. We can see that regarding the weight recovery shows 4 out of 4. Also, the height recovery shows 3 out of 4. And as we know, usually the improvement in linear growth and the height takes long time to recover. Okay. What about our aims in this research? The aims and the object in this research actually to evaluate the growth pattern in Libya HIV-infected children on antiretroviral therapy. The objective was to assess changes in height, weight, and body mass index by using what? By using a very nice tool. It's a Z-score. The Z-score becomes the gold standard for ethnic and nutritional states worldwide. It allows for precise comparison of the child's growth to international reference populations, enabling early detections of undernutrition and low growth disorders. Okay. Our patients and methods, it's designed the retrospective observational cohort study. Also, it was done at Triple University Hospital, infectious pediatric department. The study sample was 57 HIV-infected children in children's age less than 15 years from 2010 to 2024, and the variables was demographics, WHO stages, and viral load TB with anthropometric measurement. If I try to summarize this slide, my colleagues, we can see that our cohort includes 57 children with 36 boys and 21 girls. The mean age of a participant was 9.1 years, and the diagnosis was much younger, about 0.2 years. It's indicated that most of the children were diagnosed early in life and have been living with HIV for several years. According to the WHO, stage 1, stage 2, and stage 3 and 4. Well, as we know that stage 1 usually represent children who are asymptomatic or just have mild symptoms. And this group made the majority of these studies, about 66%. Stage 2, it's usually come with moderate symptoms, such as recurrent respiratory infections, and it represents about 15.8%. Stage 3 and 4, it's usually indicate more advanced disease involving severe infections and growth failure, unfortunately, taking around 18.4% of the children. Finally, the mean viral load was approximately 3.7 million copies per milliliters, showing considerably variability among the patients. Well, okay, we just take a moment and focus on this slide. We can find and summarize these tables about what? About the main nutritional outcomes before, after initiations of ART. If we found and just take care about the numbers, the underweight decreased remarkably from 39 to 13%. After what? After start ART, and that's showing significant reductions. The p-values was very nice, actually, 0.025. Also, the wasting dropped from 45% to 17%, and this change was not statistically significant, likely due to variability and sample size. Stunting improved from 30 to 12, and the difference did not reach statistically significant, reflecting the linear growth. Usually, as I mentioned before, it takes longer to recovery. The BMI on the score improved significantly, and overall, that notable recovery in overall nutritional states in this BMI was less than 0.03. Finally, children with tuberculosis comorbidities show persistent growth impairment, highlighted the compounding effects of chronic infections on nutritional recovery. So this is very important. We have to take care about any HIV patient have also tuberculosis. Well, in this figure, my colleague, we can find the distributions of weight for age on this scale. So we said, once a score, it changes. What's happened in our research? We try to illustrate the changes in weight for age on this scale among the children before and after starting antiretroviral therapy. Underweight and the poor nutritional states. In contrast, the red line showing data after ART shifts close to the 0 mark, which is for many children. Also, we can see the curve become more balanced and less skewed, suggesting what? Suggesting the nutritional recovery occurring mainly after ART initiations. In a summary, this figure virtually demonstrates the significant impact of ART in improving weight and overall the nutritional outcome among HIV-infected children. Other pictures here, in the next slide, we can find this bar chart explain for us the ART effects on BMI. This chart demonstrates the positive effect on ART on BMI over time. For more than 5 years on a therapy, both moderate and severe underweight children showed clear improvement. And the highlight how long-term ART not only control the virus, but also support health weight gain and better growth outcome. Also, this figure will give for us the TB impacts on ART, confirmed cases who have HIV and they diagnosed, unfortunately, with TB, about 4 boys, 1 girl. The mean age, it was 3.6, and the diagnosis depended on radiological and microbiological. When we see this tropometry was and PAS, that I mean as body mass index with age on the scar, we found and illustrate this profile among HIV infected with tuberculosis. In ART here, initiations considerable numbers of TB co-infected children. And here we can see that TB co-infected children usually reflecting the compounded effect on total infections and nutritional states. For more than 5 years, my colleagues on ART treatment, we can find that the children fortunately remained below the normal weight range, showing that TB comorbidity usually contribute to persistent growth impairment despite long-term therapy. And that emphasizes the need for integrated TB, HIV management, and nutritional support to achieve full recovery for those poor children. Okay, about this figure, we can find that there's changes in BMI for age Z-score among children who had both HIV and tuberculosis before and after starting antiretroviral therapy. We can find this red bar represents usually the values before ART, and the average of PAS was minus 1.47, meaning that most of children were severely underweight due to combined HIV and TB. Also, the green part actually where the PAS improved to just minus 0.67, indicate nutritional recovery. But however, since the scores remain below the normal range, this is still us that TB infections contributes to limit full growth recovery, and that ongoing nutritional and clinical support is so essential. Well, this chart, another slide that show the anthropometry presents the height for age has on these scores reflect linear growth for stunting in HIV-infected children before and after ART. We can find that most of the children were not stunted, but there were still cases of moderate and severe stunting. After 5 years, the ART we can see shift with slightly increase in severe severe stunting, and while the proportions of the children with the normal height remain nearly the same. This indicates that ART improved the weight and the BMI or linear growth recovery, as I mentioned before, that it usually remains slower and more resistance, especially in children with long HIV infections and coexistent with another infections. Well, if you will start now about the discussions of our research, I try and do my best to explain that in a simple way. First of all, we will start with this study. It's from Uganda, done in 2008. It supports actually our finding, alhamdulillah. They demonstrate that after starting ART, weight for age percentile and disease score improved significantly in HIV-infected children. Interestingly, also, weight recovery was faster than height recovery, which aligns actually with our result. Okay, another study also, as you see, it's also support our result and reinforce the importance of early ART initiations to optimize the growth outcomes. Okay, regarding to early ART initiations, another studies in Korea at 2013 done in South Africa, early initiations of ART before 6 months of age led to faster growth recovery in perinatally infected children, that emphasizing the critical importance of early interventions. Also, another study done by Dr. Williams in 2018, it reports same thing. Early ART across all age groups has restored the growth and the pubertal development, particularly when combined with nutritional support program, and this is a very important note. Okay, also another study done in Brazil in 2019 demonstrates steady improvement in both weight and height among children with HIV. Another study in 2015 done in India that highlighted that younger age at ART initiations and higher baseline nutritional status were key predictors of successful catch-up the growth. So together, these studies reinforce thus our conclusions. Early and sustained ART initiations is essential for optimal growth and long-term health outcome in children living with HIV. Okay. About this TB co-infections, we have these studies. SICA found that active TB significantly worsened clinical outcome. Also, we have GAPTA, it's done in South Africa, sorry, that incidence TB during the ART is closely linked to poor biological control, particularly within the first 6 months after diagnosis. Another study is done in Ethiopia in 2015. They demonstrate that TB co-infections delayed in nutritional and immunological recovery. So together, this finding underline that controlling TB infections is so essential, not only for survival, but also for restoring normal growth and achieving the full ART benefits. Well, we just in brief, what's our conclusions in a summary? Our finding was clearly demonstrate that the ART significant improve the growth in our country, both in weight and nutritional status. Also, early diagnosis and promote initiations of ART are crucial to achieving full growth recovery and preventing long-term developmental delays. However, tuberculosis, unfortunately, co-infections and delayed treatment, usually initiations remain the major barrier limiting complete nutritional and growth improvement. Therefore, strengthening early detections programs and integrating TB HIV management are vital to ensure that every child not only survive, but actually truly thrive. My recommendations, my colleagues, it's first of all based on our finding that we have to enhance early HIV diagnosis in children, also integrate nutritional monitoring with HIV care, ensuring that growth assessment becomes a routine part of HIV management, not an afterthought. Strengthening the AART adherence. It's very important through family educations, psychological and psychosocial counseling. Also, community-based follow-up. It's very important to maintain long-term treatment success. Encourage also further research. It's very important actually to exploring nutritional interventions under ART regime, specific effects on growth to tailor care for the child's unique needs. And our goal is clear. Inshallah, our goal is clear to move from survival to thriving, ensuring that every HIV-infected children grows healthy, strong, and full potential. Thank you so much for your kind attentions and valuable presence. It was a real pleasure sharing our finding with such an inspiring audience. Thank you so much. If you have any question, more than welcome.
Thank you, Doctor. I was just wondering if there's an increase or decrease in the amount of children being diagnosed with that.
Yes.
Are you seeing more children diagnosed with HIV or less?
Actually, this study, it was do it in 2024 in October, and the last number we collected, it was 57 child, and alhamdulillah, it's a little bit, still we have new children's, but to be accurate, I didn't calculate it, the new from that moment.
Thank you.
Thank
Any
you.
other
Thank you so much.
questions? We have some speakers that were unable to join us, so I will give my presentation at this time. And my name is Brenda Takata, and I am actually in California in the United States. And it is now Thursday morning for me, but it's 12:30 in the morning. It's good to be with you. I work on a level 3 NICU as an occupational therapist and help the premature and term babies with feeding strategies to help them improve with their intake and discharge home, and also developmental evaluations and recommendations. I would love to start with what do we expect from a normal suck pattern? I ask any student that wants to sit and see what I'm doing with the babies, how do we know that the baby is doing what they should be doing? And everybody says they should have a rhythmical suck pattern, which is absolutely true, but how do you know it's rhythmical? The suck is 1 per second, which you can obviously observe, but I love to count sucks just to see how many sucks per burst the baby does. And for a term baby, you would see 10 or more sucks per burst, and they would be doing suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. I have a fabulous video in a few minutes of a normal suck pattern, and you can just see how calm and interested the baby is compared to other videos where the babies aren't as effective. Now, our premature babies, at 34 weeks, we start offering feeding by mouth, breast, or bottle. And for our premature babies, the smaller ones, 34, 35, 36 weeks, they can handle a suck pattern of 3 to 5 sucks per burst, but they typically don't stay right in that small range. They try and do longer suck bursts, which leads them into maybe a bradycardia or a desaturation. So we have strategies to help avoid that happening for those babies. So what we typically see in our premature babies and some term babies is what we would call a transitional suck pattern, and that would be sucks between 5 and 10, Or they go above 10 and then they go down to 2 and then they go above 10 again and then they go down to 6 sucks. So they're crossing all different categories and they're not picking a pattern to stay in. So our goal would be for them to get to those 10 sucks per burst, 10 or more sucks per burst each time. To build the stamina and the energy to do that and the coordination. And we classify that when we have a transitional suck pattern or they're doing both patterns together and not picking one, that falls in the disorganized suck pattern category. So all this information is coming from a feeding evaluation that I'm part of the teaching team, the neonatal oral motor assessment scale, and you're going to get a diagnosis for the suck of normal, disorganized, or dysfunctional. So we're going to dive into disorganized right now. But I first want to say that the tongue is the captain of the feed. And when a baby has a disorganized suck, the tongue is doing its job correctly. I have a bottle here, the tongue's suctioned right on the nipple and it stays there. And the baby shows an appropriate effort for a suck. But they're disorganized if they're unable to maintain a consistent pattern. And like I said, a majority of our babies are under the disorganized suck pattern and they are just needing to grow and be, we need to provide them with a positive experience so they enjoy feeding by mouth at breast or bottle. I'm sorry, I noticed my pictures are a little bit too big, but the recommendations for a baby with a disorganized suck pattern, and I also have a baby here with me. We love to feed the babies out in front of us, not tucked into our arm. This is a much better position for a comfortable swallow for the baby. So position of sideline would be a best practice idea. And then if a baby has a disorganized suck, they have the bottle, maybe they suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. And then we tip and take the flow out so they have time to rest and catch their breath so they don't run into that Brady or desaturation problem. Regulation is intentional, usually for the younger babies at 34, 35 weeks, where we're actually regulating them at 3 to 5 sucks. Pacing would be letting them go maybe over 10 sucks, but if you notice wide eyes or they're gulping or looking uncomfortable, you again would want to tip the bottle, take the flow out, and let the baby recover. Appropriate nipple flow, we have standard flow, slow flow at my hospital. So when I first meet a baby and I'm going to do a feeding evaluation and maybe they're 34.3 weeks, I'm going to start with the slow flow to make sure I don't ask too much of them right away. That's always the best place to start. And then as they grow and they get stronger, we can change maybe what flow we're offering. But I always tell parents, it's not so much about the bottle as how the baby's responding to what's happening, and then remembering their gestational age and that they don't have to be good at feeding by breast or bottle until their due date. So if you have a 34-weeker, they've got 6 weeks to work on this skill to take full oral feeds. The babies we really want to look out for that we need to help are babies with a dysfunctional suck pattern. And in this case, the tongue is not doing its job. The tongue is either losing suction on that nipple when they're suck swallowing, the tongue is coming off. The jaw is going down, and I have some videos to show. Videos really put the picture together for everyone. A flaccid tongue is the easiest to see, but sometimes babies also have this, they all have a wave-like movement when they're sucking, but if there's retraction when they're actively sucking, the backward movement is stronger and not very rhythmical. So I try not to use the term dysfunction with a parent, but I try and make sure they understand what's going on with the tongue and how it's not doing its job. Either there's low tone and flaccid or increased tone and retracted. And a baby with the diagnosis of dysfunctional, we would want to have follow-up services for them later. On the unit, though, we also would like to provide strategies to help them with that intake. The suction is what's not as effective. So there's things we can do to help. I've got my baby again. And so if I have a bottle, if the tongue is not doing its job, I do want to get under the chin and help them improve that suction and not let the jaw drop so far. We could also use that strategy if the tongue is retracted and maybe pulling the baby's chin forward to help that tongue not make that movement so extremely. There are also specialty bottles that assist. They have a valve in the nipple to help compensate for that lack of suction. So the baby can still have productive intake on the bottle. And take full oral feeds and be discharged home. So before I show you these next videos, I did want to just say, I've been on the NICU 25 years and I read articles, and I think it's a disservice to the baby to focus on the baby is not discharged home because they aren't able to take full oral feeds. I mean, it's a true statement, but feeding is a developmental skill. So they're on the unit because they need to be on the unit because they don't have the stamina, the energy to take the full amount they need to take to support weight gain, at least orally through a bottle. So we obviously have a nasogastric tube in place to supplement feeds to help them gain weight to be able to do things better. But I always feel like the articles are saying we need to rush them to feed by mouth. And rushing them to feed by mouth is just creating a negative experience for that baby. And I love the phrase, the neurons that fire together wire together. So if we're wiring together neurons through a positive experience, that baby's going to benefit. But if we're stimulating in a negative way, that's going to affect the baby as well. So if the tongue is not doing its job, you are able to do a little more hands-on support or use a special bottle. If the tongue's doing its job, we just need to watch and wait for the baby and let them lead the feeding. So I think it's fun to pull it back into a normal suck, baby accepting a nipple, rooting, she goes into flexion, and I'll count these sucks with you. She takes the nipple 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. And I don't need to keep counting, it's a short video, but she just keeps going and she's comfortable and the jaw's dropping, but the tongue is staying suctioned to the nipple and she's doing fabulous. What's interesting about this cute girl that sort of throws it off for everybody is she is a 35 weeker doing so wonderful. So we always want to remember that each baby is their own individual person, and we're happy that she's so coordinated and doing well, but there might be a 36 weeker right next to her that's struggling, and we don't want to put expectations on them that aren't fair. So to show you some videos are worth 1,000 words. I wasn't sure if we were going to share our own screen or not, so I added these just today, in fact. But this video shows the tongue coming out farther and the tongue losing suction on the bottle. So I'm in assessment mode right now, so I'm not going to help at all. And we don't have time to show too many videos, but I wanted to show where the tongue wasn't quite working right. And toward the end of this, you can really see how that tongue falls off the nipple, and you right there as well. You're gonna know that his suction can't be great because he doesn't even have his jaw and lip up on the nipple to effectively get as much out as he should be. So we used a special bottle for him to help create negative pressure to give him a little assist, because that suction wasn't what it's supposed to be for each time he made an effort. So I'm just gonna let that finish playing out. You can see how that tongue just clicks off. So this sweet boy, we also made sure he had follow-up services after, because we're not sure what else is gonna come up for him. And I believe he was born at like 32 weeks. And during this video, he's about 35. So this next video is a video of when the tongue is retracting. Every time this little guy makes an effort, which is going to be soon, his cheek goes back and in. So his tongue is doing more backward movement than it should, which decreases his suction and ability to have appropriate intake in an appropriate amount of time. Those were both dysfunctional suck patterns. And now there's only 2 bursts here, but he starts out 1, 2, 3, 4, 5. And then he needs to rest. You can kind of see in the video all this breathing going on. And then he's going to have 1 more burst. 1, 2, 3, 4, 5, 6, 7. And he kind of hesitates, so you could either pause and start counting again, but he's not getting over 10. This baby's a little older, so that would be our goal of over 10 every time. And I do know that nipple, the yellow ring here in the United States, that's a slow flow nipple. So it's an appropriate flow for him, but he's working on building his stamina. Most of the times the kids have the skill to do this. It's just the energy to do as much as they need to do in an appropriate amount of time. And my last slide is a great demonstration of the same baby, but 2 weeks apart. So on the left side, this baby's name is Sophia. She's 34 weeks. In a couple days, she just started nipple feeding. And on the right side, she's 36 weeks. And I just want you to see the difference in how quickly she gets going on the right side, and her jaw drops and she just gets in the rhythm. But on the left side, she's doing fine, but definitely slower, and her bursts are not as long. So back to feeding is a developmental skill. Sometimes the gift of time is the only thing that's needed while you're creating those positive experiences each time. So if the baby's tired, you just want to supplement the feeding with the nasogastric tube and let them grow and mature and get better at this. So I love the side-by-side videos, so you get an idea of just the different energy and effort within just a few days. And I have a lot of stories about babies that didn't look interested at all, and we spent a lot of time just skin to skin with mom or practice breastfeeding and didn't put a lot of pressure on the feeding part. And as soon as 5, 6, 7 days passed, we just saw a big difference in their ability. Their skill set was there, but we saw a big difference in their endurance, interest, and stamina. Thank you guys for listening. I'm going to stop sharing and see if there's any questions about the NICU and babies and eating. Well, thank you for your attention for my talk. It was fun to present that. I love teaching the neonatal oral motor assessment scale because it's so objective and guides exactly what you should do for the babies. Our next speaker is Mrs. Zanab El Shabai. I hope I said that close. She's on my time zone too. And in the United States is an educational psychologist, and she's going to talk to us about empowering parents, supporting youth mental health through psychoeducation. Thank you for being here.
Hello, Brenda. Hello, everyone. Thank you so much for having me. And yes, I am on similar time zone, but all the way in Michigan. So currently it's 3:45 where I'm at. But I'm very happy to be here and to join everyone. I'm going to go ahead and just start sharing my screen. Try my best to keep it to 20 minutes. All right, can you see my screen?
Yes, thank you.
Okay. All right. Okay. So my talk for today is about empowering parents and supporting youth mental health through psychoeducation. And just to give you a little bit of a background of myself, I'm an educational psychologist. I'm also in the past, I was a special ed, and currently I'm working more specifically in testing and intervention plans and working with parents on accepting their child's diagnosis, on helping them better understand their child's brain. And through the testing and the feedback sessions, one thing that I've really noticed is that parents do not have the tools. They do not have the all the information that's needed in order to kind of help them help their children. So that's why I wanted to shed light on this and talk a little bit about the research that is behind it, all the positive research that is behind this, providing different tools, and just kind of looking at the different barriers that parents may face. Seems to have frozen while, oh, let's try it again. Okay. So why do parents matter? Parents are the child's first environmental home. When parents understand mental health, they create safety. And this is why today we're going to explore how psychoeducation kind of bridges that gap between understanding and action. And globally, an estimated 1 in 7 adolescents experience a mental health condition. And an estimated of 60% of youth have a diagnosis, but they don't receive the appropriate care that they need. And in the US, nearly 70% of parents don't have the, whether it be the education on anxiety or depression or autism or ADHD. And now I just want to take it back to, the Arab region. I worked in Lebanon and I still do. So I work between the States and Lebanon. And you can just imagine what those numbers are probably like, because it isn't that apparent that we are more accepting with diagnosis, especially when working with parents. Now, parental engagement is a significant influence, and I'm sure as we've seen, both positively and even fortunately negatively in a child's mental health journey. Now, parent involvement definitely correlates with reduced adolescent depression. And we'll see later on as well that it has to do with even reduced defiance, reduced oppositional defiance disorder. But what is psychoeducation? It's the process of teaching psychological concepts in an accessible, practical way to enhance understanding and coping. And one thing I want to mention as well is the culture. So when we're working with our families, the families that come to us at the practice, we want to make sure that we understand their culture as well. So during the intake process, we do have questions about their culture. Whether it be religiously, where do they come from? What are some of their values? Because we want to make sure when we get to that feedback session, we're providing them with the appropriate tools that are consistent with the values that they adapt at home. Because that's the only way that it will work. And that is one way that parents will be accepting of it, because not all westernized theories can necessarily be adapted without any modification in more of a collectivistic society. So it starts with awareness. So usually during the sessions, you're of course giving them the definition of, what is anxiety, what is depression, what is ADHD, and providing them with an understanding, making sure that they understand what their child is going through, using specific terminology. So, we do have to use those big medical words, but then also providing them with kind of an example of it. So when, I'm telling them, your child has some weaknesses in processing speed skills, I also want them to understand what that means. So I might say, imagine that they're in a classroom and there's a new concept that the teacher is explaining to them. And, it might take them a little extra time to kind of understand that. They just need some extra support or some extra time or certain visuals to help them understand the concept. So I start there and then I transition it to the home. Like, maybe sometimes you might ask them to do something and you realize that, it takes them a minute before they start doing it. Or if you give them a couple of instructions at one time, they might not be able to do them consecutively. They might forget. They might be a little bit, whether it be slower, they might ask you follow-up questions. And just relating that, helping them understand it, and then transitioning it into action. Okay, so what can we do? And I found that this way is parents are more accepting of it when you are not only just providing them with the definition, just what it is, what is anxiety, but helping them understand how it's affecting their child's day-to-day, and then providing them with the action plan. And psychoeducation, I have seen reduce the stigma, improves treatment adherence, and strengthens literacy as well. And it also improves caregiver well-being and engagement with their child. Now, there are barriers that parents face. And these are some of the different types of barriers. Now, a lot of times I'll see that parents may be kind of resistant because they have a certain idea of what anxiety is or what depression is. And what psychoeducation does is it kind of dismantles this. It dismantles these defenses by reframing mental health as a learning opportunity, not a reflection of failure. Because many parents, when we do come to them and we provide them, we say, the results, or, your child does have an anxiety disorder, or they are expressing depressive symptoms, a lot of times parents will blame themselves. So the first barrier is the cognitive barrier, which is limited understanding or misinformation about mental health. And this is the usual, they'll grow out of it. Anxiety is just overthinking. Depression means laziness, without really understanding what's going on in that child's mind, what's going on the inside. Now, the emotional, which I kind of touched upon just now, is the guilt, the shame, or fear of being judged. So a lot of times, as I mentioned, they might put the blame on themselves. And we also want to dismantle that. We want to tell them that has you, the way that you have been parenting, but there are certain actions or strategies that we can apply. If I admit it, I failed as a parent. So there are times where we will share with parents, we'll provide the psychoeducation, hoping, and we'll provide resources, hoping that, the parent will be accepting. Sometimes I will say that it does fail. So it's not just, every time that we do the psychoeducation or we provide the resources or we provide the explanations that parents will be accepting. Sometimes it takes a little bit of time. So in those cases, I'll usually be like, just take a couple of weeks, take a month, a few months. And if you have any additional questions, come back. And most of the time they do come back. I had a parent come back after a year. Finally accepting and kind of ready to move on with the intervention plan. And many might just say, my child is fine. The cultural and societal barriers, and these are cultural norms that I'm sure that we've all heard, such as, boys shouldn't cry or boys don't cry, therapies for crazy people. We don't discuss this outside of the family. So we the way that we help with this is usually matching the child with a therapist of similar cultural background, because usually parents are slightly more accepting to that, but still it's something, unfortunately, that is taboo, especially therapy, especially since this conference is in Dubai, so especially in the Arab region, it's getting better, but I feel like we still have a long way to go. And in order to help children, I feel like psychoeducation definitely is the first step. The last barrier that's faced is practical and systematic. So here we're talking about no time for workshops, financial limitations, which unfortunately do happen for a lot of families, language mismatch, and rural or low resource areas. And there were some studies that, showed that even digital psychoeducation, so such as workshops, are just as effective as in-person workshops. So there has been more accessibility to that in that sense. So that's kind of the positive of it. But again, we're facing that financial limitations. Now, what the latest research has shown, research is pretty much it has reached a consensus that psychoeducation does help improve child's youth outcomes. So adolescent treatment outcomes, externalizing behaviors. So here we're talking about aggression, impulsivity. There was a reduction in even, aggressive behaviors in other studies or antisocial behavior. But again, what remains is that access and equity barrier. And what has also been shown is that, the school and the community programs are key connectors. And multi-tiered approaches work best, which I'm going to touch upon. So I just want to go over the practical psychoeducational strategies. So how can we empower parents? First, we can help them by recognizing that it's important for them to normalize conversations about mental health. Talk about mental health early and often, and replacing those clinical terms. Now, conversations don't have to be perfect. They just need to be present. And what I mean by using more relatable language is like, brain health, stress response, emotional energy. So instead of, labeling, just using the labels like depression or ADHD or anxiety, just providing them with relatable language. And there was one adolescent that I worked with, and he was having a difficult time just kind of understanding why he's going through what he's going through. And he's really into computers, processing, all of that. So what I did was, I came up with a metaphor and I explained it to him. And I was like, just think of, you're working on your computer and then all of a sudden you get this virus and all of these pop-ups just keep popping up on your screen. So that's kind of like, when you're worried, all these tabs are flashing on your screen and you don't know what to focus on and you start to get overwhelmed. And then here comes, kind of the attention difficulties or attention differences. And you don't know what to focus on first because there's just so much going on. And then your computer shuts down. And that's how you feel when you shut down. And just time after time, explaining those different situations and giving that metaphor helped him understand himself more. And then after the understanding part, also going into the action part and having the parents be present. So majority of the time, parents are present in those kinds of conversations so that they can use those tools and apply them at home. And using routine check-ins. So what was the best part of your day? How are you feeling on a scale of 1 to 10? Just kind of talking and being more of active listening. So listening to understand and not to fix, because as parents, the first instinct is, to fix what's going on or to fix, whatever problem your child's going through, but kind of actively listening and just asking questions, besides how are you feeling, what would you do, or what could possibly make you feel better. Okay. And then, of course, being more open to it's okay to feel big emotions. And what's important during this conversation is parents will be able to recognize those early signs. So parents often ask me, How do I know when it's serious? And that's something that's important for parents to understand, is that, developmental changes can be confusing, and the duration and intensity, though, matter. So if a child is consistently withdrawn, they show low motivation or become self-critical, it's time to check in, not just with their child, but also with a professional, if needed. And one last thing is that, when children are involved with their, with parents, they kind of talk it out. It kind of improves engagement, especially when we're talking about kind of the coping skills and intervention plans. What's important also is to build emotional literacy. So naming it to tame it. So when we're teaching parents about emotional intelligence and the importance of it and how to label emotions and how they can kind of help. A lot of times parents will start therapy at the same time of their child, so that they can process their own emotions as well, because we're all human beings, process their emotions, develop those coping skills so that they can reinforce those healthy model expressions with their child, and making sure that they focus on connection before correction, understanding why that outburst happened, understanding, why, what's the reason behind the defiance. As I mentioned, practicing those skills, so usually co-regulation, making sure, because research has shown, and we know this, that children learn regulation through the caregiver's nervous system cues. So, and we see that a lot. And we've seen it, even in meetings when parents will come and the child will be there if the mom or the dad is extremely anxious or extremely negative or angry. It reflects in the child as well in that situation. And there are different techniques that can be done, such as I have on the screen, the box breathing. So this is something that's a very simple kind of technique that I teach parents, just to even, when children are having their big feelings, sometimes it might be hard to express it right away. So just kind of practicing, trying to get them to self-regulate and practice these skills. But we teach parents those skills first, because they are the models. Again, the reason why we're having this talk is, and the reason why we should empower parents, is because they are the initial environment, the emotional environment for the child. And then, for example, if a child has elevated anxiety symptoms, and it doesn't have to be necessarily a disorder, but just has elevated anxiety symptoms, providing them with predictable routines helps a lot. Helps them with kind of knowing and what's to happen next. Modeling coping skills, as I mentioned, to show, don't just tell. So a lot of times parents will come and they'll be like, we tried that. We tried the journaling, we tried the breathing, we tried all those, but it's not working. My next question is, have you tried doing it and modeling and seeing what works for you and sharing what works for you and what doesn't work for you, so that they can find something that works for them, and just kind of discussing it? And the most important thing is the circle of support. It's important to have the parent, the educator, the clinician, and the child. It all complements each other. When we empower the parent, they're able to kind of also assist the school. Is there a counselor at school? Can the counselor assist? Do they need therapy? Do they need testing? And then build that intervention plan and then help the child out. So it has to do with connection, communication, and consistency. As I mentioned throughout, the research is clear. So even if I want to just go back for a second with the emotional literacy, there was a 6-week program, a study that they developed, an emotionally focused therapy group for parents for 6 weeks, and the results were amazing. Just showing how much when we're teaching parents about their emotions, teaching them how to identify, warning signs, like to call them, in adolescents, and how to, or in children, youth in general, and how to combat those. So what are the next steps? So empowering parents through psychoeducation provides us with consistent communication with schools, equitable access to culturally sensitive support, these all lead to better outcomes and treatment engagement for youth. So the key takeaways is we want to change these we want psychoeducation to transform confusion into understanding. Empowered parents become the protective factors. Connection precedes correction, and learning together does build resilience. So we need to understand to be able to support and prevent. So my call to action is to keep the learning going, attend local or online parent workshops, or even if you work with parents, which from what I've seen today, majority do work with parents, even from a medical standpoint, just trying to follow evidence-based mental health education platforms. There's so much information out there. So making sure as well that we're providing parents with the appropriate resources or with the appropriate information, and creating school parent partnerships, because when the school understands kind of what's going on at home, they can keep an eye out at school and see, is it similar at school? Are they more internalizing instead of externalizing, and knowing how to proceed? And that's the end.
Thank you so much. I would love some advice on how to communicate to kids and address social media.
And this is something that we often get asked about. With social media, it's very important, and it depends on what it is. So if we're talking about, like body image, or, certain, so if we're talking, for example, usually girls are more affected by body image or their looks, is just trying to, one, kind of reduce the social media intake. Sometimes it's easier, sometimes it's not. And just focusing on their strengths. So it depends, but addressing social media, it is difficult, because even if parents do limit, they can go to school and simply everything is on the iPad. So the way that we empower parents is we try to educate them on social media, the effects of social media. So we bring in, different evidence-based research. And we also at first really teach them about the security of social media. Because as you know, and I'm not against it, there's a lot of parents who are influencers who post their children, sometimes posting their children in vulnerable states. So we want to educate them on that as well, and on the long-term effects. And then, so after educating them on the safety of it, we teach them how to teach their children how to be safer on social media. And they have to consistently, just kind of observe, whether even if it's going through their phone or going through their social media, just making sure that they're on top of things.
Thank you very much. Any other questions? Thank you so much for that wonderful presentation. We will move on to our next speaker, Dr. Sahar Kameya from Canada, a Lebanese Canadian child and adolescent psychiatrist. The talk will be Understanding Attachment Disorders in Childhood, Theories, Manifestations, and the Circle of Security as a Treatment.
Yes, hello, thank you so much. I
Thank
think
you.
the PowerPoint on the screen.
Not yet.
Oh, okay. Maybe while it's being put on, I can start by introducing myself. Do you hear me well?
Yes, we can hear you. Oh,
Okay,
and your presentation's up now.
Perfect. Hello everyone. My name is Dr. Kmeha. I'm a child and adolescent psychiatrist. So I am an MD, a doctor who specializes in child and adolescent mental health, diagnosis, treatment plans pharmacologically, but also psychoeducation. I work at Shahamwan Hospital in Quebec, Canada. So that's a French-speaking province. So I apologize in advance for any French that might slip in while I'm presenting. I'm very happy to be here today, and I thank everybody for this great opportunity. I do not see myself while talking. I think that's okay. We can change slide, please. I do not have any conflict of interest to declare, but I do want to tell everybody that it's 4 o'clock in the morning here, so I'm a bit tired. And this not might be my most dynamic presentation, but I'm very glad to be here. We can change the slide. So I changed the title for it to be more precise. Today we're going to talk about attachment theory, attachment in general, attachment disorder, its epidemiology. How do we assess it as psychiatrists in a clinical setting? How the diagnosis is made, some of the differential diagnosis that is quite challenging in clinic, the frequent comorbidities, and treatment plans as per ACAP, so the American guidelines for child and adolescent psychiatry. We can change slides. So what is attachment? We have to understand attachment first as a survival mechanism at first. So the closer we are to the caregiver as a child, the higher is the survival chances, higher it is the probability it is for us to be fed, to be taken care of, to be protected, to not be cold. So at first, attachment is the most basic need that help a child develop his other needs physically and then mentally. A child develops a preferential attachment to one or few significant adults during the first year of life. So studies have shown that it's really the first year and up to the second year of life when attachment is formed, and it's formed through consistent and responsive caregiving. Around 8 and 9 months, this is when a child will exhibit stranger anxiety, and in that, we would see a child that would seek comfort from the attachment figure when under stress and not from unfamiliar persons. The highly selective attachment in relationship is established through a deep emotional bond that is formed between the child and his caregiver. And when the caregiver is lost, when this figure is lost, we would see a child that exhibits behavior of grief and disturbance, which is normal. So when attachment is established in a healthy way or in a secure way, as we would talk more during this presentation, this is when a basis for healthy and social base for healthy social relationships later on in life is developed. And I do believe, I'm from the school of thought, that it is the basis for preventing psychopathologies later on in life. When attachment is disturbed, this is when psychopathologies can happen later on in life. We can change the slide. Thank you. So the father of attachment, John Bowlby, I don't know if a lot of people have heard or read about him, but he has a lot of interesting thoughts. And he is the one that introduced attachment as an innate and motivational behavioral system that is combined to a relationship and emotional bond to the caregiver. And the child will adjust its proximity-seeking behavior to maintain his safety. And this is where the idea of secure attachment is introduced. Once attachment selectivity is established, the child will seek comfort from the attachment figure, especially when feeling of stress is present. And the child will exhibit a lot of sadness, a lot of disturbance, a lot of angerness also when this figure is lost. It is Mary Ainsworth after Bowlby that introduced the ideas about attachment quality. And once the attachment is established, how does the child relate to the caregiver? And this is the idea of secure and insecure attachment. We can change the slide. So around 12 months and her experience of strange situation that you can watch on YouTube. It's very cool to watch it. I do it to all my residents. I watched it with them and they're like, huh, didn't know that existed. She was able to establish two big subtypes of attachment, the organized and the disorganized. And in the organized, this is when we would see fragility in attachment. So there's the secure, that's the attachment that's well established, but the fragility that's in the insecure, the avoidant and the ambivalent. The avoidant is linked to maternal rejection. So every time the child was seeking comfort from the mother, and mother and M majuscule and big M, that means any caregiver that's present for the child was not received in his comfort-seeking behavior and has learned that I cannot rely on this person, so I will act as if I am not bothered by what's going on. And the ambivalent or the resistant type, this is when the mother, again, the caregiver, was unpredictable in her responses. So when the child came back after his social and attachment battery was running low, it was not received in the sense of maybe the mother was angry or grieving herself, and sometimes was received so the child doesn't know how to position himself. And all of this goes against the disorganized pattern that was later added by Maine, where a child doesn't know if the caregiver is his caregiver or the reason for his suffering. So this is cases of abuse, for example. I will talk about it a bit more in the next slide. We can change the slide. 3 subtypes were identified. So the controlling punitive type, that's associated to a caregiver that's dealing with complex trauma. So in that setting, the child is more controlling in an authoritarian way and scares the caregiver. The caregiver usually has experienced trauma and abuse in their childhood. I have seen an example of that in clinic where the child comes into the office and the mom sits on the chair. There's a little chair for the child and he's like, hey, you get up. This is my chair. And the mom, all scared, changes places without saying nothing. Then there's the controlling caregiving type that's connected to unresolved grief in the caregiver. Usually the caregiver has lost his own attachment figure early on in life. So this is when the child assumes the parental role in order to keep the parent engaged in the relationship. For example, a little girl that I had in clinic that was always offering the mom that's dealing with depression, her drawings, some food, making sure that mom, hey mom, are you cold? So always being afraid that the mom's needs were not met when she was the one in the psychiatrist's office because things were going very badly at school. And the third subtype, where there's a lot of disorganization at the behavioral and language level, that's associated to dissociation in the child. Usually the child is very fearful. So a child that would be playing, all of a sudden the play would stop and he would utter words as if, oh, I don't know if mom and dad will be here tomorrow, and then goes on to playing. And when questioned about what's going on, he said, no, I didn't say that. We can keep going. So why do, change slides, please. Yeah, thank you so much. Sorry, I just want to back up the presentation. There we go. Okay. So why are we talking about attachment and fragilities in attachment? Because those children present with behavioral problems, with impulse control problems, with conflicts with the attachment figure, especially oppositional behavior. A lot of low self-esteem that later on is grounds for internalized disorders such as depression or anxiety, and poor peer relationships. They want to have relationships, but things are hard for them. We can change slides. So what we talked about earlier is the attachment theory and difficulties in attachment as understood by the theory, but it is different from what DSM. This is the manual that we use in Canada. We do not use the ICD. So the DSM-5 talks about. The DSM only presents two subtypes of attachment disorders that's classified under trauma and stressor related disorders such as PTSD, acute stress reaction. So the two types is reactive attachment disorder that we would refer to during this presentation to RAD, and the disinhibited social engagement disorder. For the sake of time, because we only have 20 minutes and 12 has already gone, we would only talk about RID today in the presentation. We can change the slides. So attachment disorder, next slide, please. Thank you. Attachment disorder has been observed for a long time now, before DSM-5. So there's a study in 1977 in a group of children in residential care in London, so an orphanage in London, that were observed through time. And there were patterns of behavior that were observed. Some children were not able to establish a secure relationship with the caregiver and exhibited emotional withdrawal and lack of response to the caregiver that will later be identified as the RAD and the DSM-5. And others that were seeking excessive attention, that were clinging a lot to familiar and unfamiliar types of adult, and that was the disinhibited type that later on would be the disinhibited social engagement disorder. Also, some of these children were living under the same roof with the caregiver, but managed to develop later on preferred attachment to the caregiver. So even though the environment was the same, the attachment pattern were different, and there's many factors to that, the type of neglect, the intensity, if there's abuse, the genetic factor, generational traumas that were present that made the attachment pattern different for each child. We can change the slide. So reactive attachment disorder per DSM-5 TR. First of all, it's a pattern of the inhibited and emotionally withdrawn behavior. So the child doesn't really seek comfort, doesn't really respond to comfort when in distress, and doesn't seek protection, which makes them more vulnerable and more at risk for other types of abuse. We can change the slide. And in the behavior, we would see either a lack of response or a very limited positive effect. I feel like there are children who don't really exhibit joyfulness or la joie de vivre, being seeking a child that's happy to play. That's very difficult for them. And usually there would be episodes of irritability, sadness, fearfulness, and a lot of dysfunction socially, academically, and they will end up in my office. We will change the slide. Social neglect and deprivation is present in their history, also repeated changes of primary caregiver, or a setting that didn't allow the child to establish a form of selective attachment. We can change the slide. The criteria of exclusion is ASD, so we cannot diagnose ASD, autism, and RAD at the same time. And the disturbance happens before the age of 5 years old and after the age of 9 months old. If it first appears after 5 years old, we have to reconsider the diagnosis. We can change the slide. So developmental delays, language delays, motor delays are seen, or also stereotypies. And this is when usually the consult would be, is it RAD, is it ASD, what do you think? You can change the slide. There are so fortunately, it's not a very frequent disorder. Not all neglected children would develop RAD, fewer than 10%. Even in the severely neglected would develop RAD, usually before the age of 5. And the good news is the post-neglect caring is very important to improve prognosis. And these children do better once they are placed in a better environment. We can change the slide. So there are similarities between RAD and ASD, as both have reduced expression, cognitive delays, disturbance in social interactions, and some stereotypies that in RAD are more for auto-soothing and versus ASD. We can change. But in ASD, there's rarely a history of neglect. There's more restrictive interest than in RAD. There's more ritualized behavior and more sensory issues. And the attachment usually in ASD is quite normal versus AAD. We can change. The comorbidities are very frequent. Cognitive delay, language delays, usually because of understimulation and neglect, post-traumatic stress disorder, and adjustment disorder. Depression, anxiety is also present. We can change. So what do I do as a clinician once I receive a consult for RAD? It's important to, we can change the slide, thank you. It's important to get a history for the preferential attachment, a detailed history of who was the caregiver during the first year of life, who was present for this child in their life, what changes did he have, what kind of issues was the caregiver dealing with and transmitted. And the speaker just before me was already talking about how the needs of a child goes through communication with the caregiver and how the empowerment of the caregiver helps the child. So was the caregiver empowered at that moment? Was there any postpartum depression, any other psychopathologies that were present in the caregiver? We can change. So the detailed history of how the child seeks comfort when in distress. How did the caregiver receive comfort in their own childhood? And when was the age and onset of stranger anxiety? That's a very important cornerstone. And we can also ask for the caregiver to leave the room and see how the child interacts with the stranger, myself, during the assessment. And how does the child react once the caregiver comes back into the room? Are there any signs of distress? Is he comforted, not comforted, angry, hitting the mom, or acting as if nothing happened? Or in disorganized settings, the child completely disconnect or stays fixed at the door and doesn't know what to do. We can change the slide. So very important, the next one too. During assessment to determine if there are comorbidities, as they are highly present and can cause impairment in social and family and psychiatry functioning. And as a child psychiatrist, I work a lot with youth protection to see if the placement of the child where he is actually secure right now, and helping the child feel secure, so to avoid re-traumatizing the child. So we can do recommendations to the court or to the youth protection for that setting. We can change it. And we change again. I'm going through a bit faster because I see the time going, so a couple of minutes left. So we'll go right into treatment. So attachment disorder are a relationship disorder. So treatment is based and focused on the relationship between the parent and the child. There are various ways where we can help both parent and child feel secure in their relationship. There's dyadic therapies, psychodynamic therapies, the watch, wait, and wonder, where we help the parent observe and help them mentalize the need of their children. There is a lot of video feedback, such as play therapy, that we do at the clinic, but the one that I'm more interested in, and the one that I practice more in my clinic, and that I've seen treatment of, and when I tell the parents, I'm like, I believe in that, it really does work, is the circle of security. We can change the slide. So the circle of security targets at-risk families and those already involved with child protection services, but can be used with every parent. I myself, as a parent, have benefited from the circle of security. Just to be in a position where I understand that the child's behavior comes from activating or deactivating his attachment mechanism. What is the child seeking? What is the need behind the behavior? So this is really the spirit of Circle of Security. It uses video feedback, so it's 8 seances, 8 sessions that through videos help the parent reflect and question and observe the child's behavior, and for them to identify the need, the attachment need behind it. So, and there's a lot of attachment psychoeducation that is related. We can change the slide. So Marvin and Cooper, who are the founders of the Circle of Security, identified this treatment as a visual map of attachment. It is used in parents' education and intervention programs to help caregivers better understand and meet children's attachment needs. It depicts that there's an interplay between a child's need for exploration, so going out in the circle, and their need for comfort and safety, so coming back in the circle, with the caregiver acting as both a secure base or a safe haven. So we would talk a lot about the hands. We can change the slide. So you would see a secure, when there's a secure base, the child is able to go explore the world. And while the child is exploring the world, the caregiver's role is to watch over him, to delight in him, to help him, to enjoy time with him. And once their battery runs low, when there is stress, discomfort, the child will run back into the parents' hands and the safe haven to be protected, to be comforted, to be delighted also. And most importantly, to be co-regulated, so organize my feelings would go into play. So some people have more difficulties in letting the child explore. So usually caregivers who have experienced trauma themselves and or have difficulties receiving the child. So also other types of trauma that's associated in that. And the idea of the Circle of Security is not to identify the traumas of the caregiver, but for them to identify that something is there and is blocking either leaving the child to explore or receiving the child. And in that, there's a behavior change in the parent, and we would and the child will have more facility either exploring or being received. And in that, there's better co-regulation, and when there's better co-regulation, there's better regulation for the child. We can change the slide. So this is their website. They do a lot of workshops around the world in many languages, and the Circle of Security is offered in over 100 languages. We do it at the clinic in French and English, and I have the opportunity also to be Lebanese and Arabic speaking, so I do it in community other than clinical setting to help to empower parents. We can change the slide. I leave you with the famous words of Bowlby that for me it explains a lot of psychopathologies and gives me hope also when I see most severe cases in my clinic, that there's a way to repair, there's a way to give this child more joyfulness and more meaning to his life. Is what cannot be communicated to the mother cannot be communicated to the self. So attachment is communication, is helping the child identify his own needs. And it starts with, oh, you're crying, you might be hungry. It starts day one in life. And it goes on later on for the child to be able to understand himself, to regulate better. And when there's better regulation, there is less psychopathology. Last slide. So those are some of the resources I have used, and all the last slide after that. I really wanted to say the templates, I got them from Slides and Go. It's a very cool website, and they were offered freely. That I encourage everyone to use. And I don't get anything from that, but I found it really cool, and I wanted to leave you with that. So that's the end of the presentation. A little bit more than 20 minutes. So thank you so much for your attention and the opportunity to speak here today.
Thank you for your presentation. That was wonderful. We will go into our next speaker, Dr. Uma Busha from Canada, and her research focuses on applied behavioral analysis and developmental interventions. Excuse me. The talk will be on effectiveness of video modeling to teach imitation skills to children with autism in an underprivileged community on the island nation of Mauritius.
Good afternoon, Dubai, and good afternoon, everybody on the panel. Can you hear me?
Yes.
Okay. So I wish I was there because I love Dubai, but because I've been sick for the last 3 months, I couldn't come. So let me see here, my presentation. Okay. I have a lot of slides, but there are some parts I'm going to just ignore and then go on to the main points. Otherwise, it's going to take too long. So, slideshow. Page 1. Okay. Can you all see my slides?
Yes.
Okay, thank you. So it has been a privilege for me to prepare for this conference, and like I said, I wish I was there. Okay, now option. It says that I'm viewing. Okay, go. So the purpose of my study was to investigate the effectiveness of video modeling to teach imitation skills to children with autism in an underprivileged community on the island of Mauritius. So this is where I was born, and then I left there when I was like 20s. Okay, so my research question was, will video modeling be effective in training imitation skills to these children with autism? Those children who don't have like the privilege of having any like iPhone or iPad or something like that. Okay, so I'll give you a brief overview of autism. The skills deficit. So children with autism have difficulties in communication skills, both receptive and expressive, imitation skill, social, emotional, inability to relate to others, restrictive and repetitive behaviors like jumping or flapping hands and walking on the toes. And then they lack independence in daily living skills. Some of the kids, even like 8, 9, 10 years old, they don't know how to put their shoes on, the shirts on, and even they don't know how to feed themselves. And the last one is gross and fine motor skills. So they have like they're walking on the toes, or they are walking with a gait. They cannot climb on top of something. Okay. So we'll touch briefly on global prevalence because it's about autism across the world. So it was found global burden of Diseases found that there was a decrease in prevalence of developmental disability in children 5 years or younger in all countries except North America. So there was a decrease, and there is some reason why there was a decrease. It's probably because the diagnosis was not done. They don't have enough people, professional, to do the assessment and all that. So that had happened between 1990 and 2016. But there was a significant increase in number of children with developmental disability in sub-Saharan Africa, North Africa, and Middle East. The percentage is quite high, especially in sub-Saharan Africa. It was 71.3% increase. So again, probably the diagnosis was like, they had people to diagnose and all that, or sometimes parents don't want their children to be diagnosed because like they don't like the community or their family members to know what's going on with them. And the highest was in South Asia, like India and all that, and the lowest was in North America. Okay, so global prevalence of autism, increase in prevalence globally, but varies within and across social demographic groups. Some countries, they have people who have some money and they are able to do diagnosis and they are able to do assessment and get treatment for those. But it is less likely to be diagnosed in developing and underdeveloped countries. There's some reason for that. The lack of experienced staff, diagnosis tool, lack of resources, family reluctance to get a diagnosis. So in Mauritius itself, there's 1 in 93 individuals who have autism, whether it's diagnosed or not. And the population of this country is only 1.3 million. I think now it's 1.5. And there are more male than female who are diagnosed, and number of female diagnosed are not known. Estimates of prevalence higher than reported according to the NGOs in that country. So imitation is the topic of this research. So we'll touch base on imitation a little bit. So imitation is that a learner will emit novel targets without exposure to model or without explicit reinforcement. New skills are acquired quickly and considered as an important foundation skill. It allows for acquisition of many other skills. So unlike typical developing children, kids with autism or developmental disability, they need training for children with ADHD. This is one of the researchers, Ingersoll, in 2012. She had mentioned that. Okay, so there are various behavioral interventions to use to train imitation skills. These are all research-based. First one is discrete trial training. Another one is pivotal response training. This one is where we follow the child's lead, and then accordingly we will teach some skills there. Reciprocal imitation training will be like the parent will sit across the child and will do like clap your hand. So the child will see how it is done and then he will do it. But for some kids, it is difficult. Then we'll have to do some prompting and all that. And then video modeling is a research-based intervention. And this helps the child. And video modeling is well documented, it's evidence-based, and it is an effective intervention. So some behavioral intervention to teach various skills. The skills are like language and communication, play, pretend play, social skills, life skills, imitation skills, vocational and social skill, among others. Okay, but there are some challenges with video modeling. It's not like, it doesn't work all the time. Not always effective in teaching skills, any of the skills that I mentioned. Some possible explanation for these challenges are, first of all, lack of attending skill. Second is like the child has poor eye contact or no eye contact. So if he doesn't have eye contact, he's not looking at what is being done for him to copy, he will not be able to do it. Joint attention challenges where the child is not able to like pay attention to the other person, pay attention to the like the toys or anything that we move around. So then that creates a challenge. And then inability to scan the environment or track stimuli. So if he's not able to look around and see what's going on, this becomes a challenge with video modeling. Lack of motivation. If you're trying to show him something and he's not interested in that, but then he's not going to attend to that. So attending skills is very important. It is a collection of verbal and non-verbal behaviors that facilitates listening and communication. Various components of attending skills, this orienting gaze towards the object or the person, shifting, disengaging attention from one stimulus to another or from one person to another. Social attention, that's naturally orienting attention to others' voice, like say child is standing there and mom is talking, and then he's going to like pay attention, look at mom's faces because he heard her voice. And it's likely essential for video modeling. So attending skill is very important for video modeling. Okay, so joint attention is all components of joint attention is, first of all, the child orienting towards the partner and attending to stimuli, shifting gaze between people and object. So if you have a ball in your hand and he looks at you, you put the ball in front and he's going to orient his gaze towards the ball. So that's joint attention. Shifting gaze between people and object and following okay, this presentation is not really working. Okay, let me continue. So we have a lot of literature review on previous research. So I'm not going to go through all the research that I have done. I'll just go through on few of them. So video modeling on imitation of play skills. That's in 2010. Generalization of previously mastered goal was promoted. And video modeling on generalized imitation of facial model. So imitation training, modeling, prompting, differential reinforcement, error correction on 3 participants in this study. And the results show that all participants learned to imitate some of the facial model, but only 2 demonstrated generalized responding across stimuli. So joint attention and video modeling, Dawson and al. In 2004, they tried to establish joint attention. So there are 3 groups of young children with autism and developmental disability and normally developing children. Overall performance in group with autism significantly lower than other group with regards to joint attention and social orientation. Impairment was more pronounced in this group, and it indicated that children with autism have challenges in joint attention. Video modeling are used to establish a lot of other functional skills such as language, conversation, social, life skills, and among others. Okay, my slides are not moving well. I'm sorry, my slides are not working. Okay, just give me a second. I'm going to try to fix it.
We can see it. Is it not advancing?
You can see it now?
Yes.
Okay. Okay, all right, joint attention and video modeling. So we found out that joint attention is important for video modeling. And previous research, we've done that. Can you still see?
Yes.
Okay.
I wanted to ask if it's okay right now, since this is an underprivileged area, are you working with parents to train them on doing the video modeling?
Yes, so I met with them after the after the sessions, and then because I am in Canada and they are in Mauritius, I gave them a bunch of strategies to work on. And after a few days, a few weeks, they stopped responding to me. So, but I gave them everything that was necessary. Okay, so there has been a lot of research on video modeling and different skills to teaching, like imitation and language and facial expression and all that. But there are limited research on generalized imitation through video modeling. Attending skills, this is a possible prerequisite for video modeling. It was not mentioned in any of these studies on generalized imitation. Therefore, more research is needed to assess whether attending skill is a prerequisite for generalized imitation using video modeling.
You can say next.
Okay, so
and
summary of the research studies. Video modeling is deemed to be an effective training for various functional skills and behaviors, language, communication, social skills, life skills, and many others. So prior to the study, I had four kids who I found that they were eligible. They were between 4 and 10. They were able to follow one-step direction. There was no challenging behaviors. And then they had no ABA treatment or SLP or OT previously. They had limited imitation skills. The two of them had no imitation skills. Two of them had some imitation skills. So I'm going to skip the method. There were 4 children with ASD between age 4 and 10. And the treatment happened in their school. So I had a classroom where I used to take them each. And the design that I used was a non-concurrent multiple baseline design across participants. So I will be working on one first and then work on the 3. The first one will be as soon as it gets a steady baseline, then I move on to treatment, while the 3 others are still on baseline. And the independent variable was video modeling, and dependent was number of imitation goals mastered, and also trial to criterion to master this goal. So I did kind of a pre-experimental phase with them. I did a pair with them. I did a reinforcement assessment using the brief multiple stimuli without replacement of 3 toys. And then also I used the MIS, the motor imitation scale pretest, to see how much imitation skills they have. And I used the VB map just for the attending skill and imitation skill. I didn't do the whole set. And I created videos. There were 10 targets videos. Okay, so I'm going to skip this one. Procedure phases. There was a baseline, intervention, generalization, and maintenance phase. The maintenance phase was done only for two of the children who reached the criteria for mastery. Okay, so baseline, I had 2 sessions daily for each child, between 20 to 30 minutes. And the second intervention was 2 sessions daily, again 20 minutes. I started first on the participant Kimani with most stable baseline, and after 4 sessions, baseline continued for other participants. After the 4 session, I started treatment for Kimani. So intervention procedures, I established attention first. Target was shown on the screen, then pause, and then the instruction was your turn or do the same. So I used the local language there. Okay. Okay, so the intervention procedure was same thing as the baseline, but in the baseline, I didn't teach them. I just took the data as it comes. But in the intervention, I tell them do the same and then wait for the response. The correct response will be that he's going to do the imitation piece, and then he was provided with the reinforcement, and then next action shown. If the incorrect response, then I would do error correction, prompting, and all that. Show the action again. If the error occurs with 3 poems, then I will move to the next action. Okay, so these are the response, correct and incorrect. So they had to give a correct response within 5 seconds after viewing the model. And I had no conversation with them except for giving them the instruction, do the same or pick up more. It's it's in French. Prompting procedure, I use a delayed most to least prompting procedures to correct errors with no response within 5 seconds. So I use full physical hand over hand, say a clapping hand. So I will hold his hand from back and then do a full physical. Then partial, just hover hands over the arm lightly. Okay, so data collection, there were 2 types of data collection. 3 types, percent of correct imitation response per session for each of the children and for each phase. And then trials to criterions data, and then the motor imitation scale pre and post test. So pre was before I started this intervention, and the post test was when all the maintenance and everything was done. Then I take a post test. And generalization and maintenance. After mastery, 3 new novel stimuli were used to assess if the imitation occurs. So it occurred in 2 participants, K and V. No prompt, no reinforcement was used, and they passed. The K got at least 100%, and V got 85%. Maintenance, because of due to lack of time, only 1 maintenance session was conducted, and that also on only 2 participants, K and V, because they had reached the mastery criteria. So the results, this is the graph display. So you can see the baseline for Kimani was after the 3rd or 4th data point, his baseline became stable. Then I started immediately the intervention, while the 3 others were still in baseline. They took a longer time to reach kind of a stable baseline. But at the end, Kimani, he was the best. He got mastery at least at 90%, and the other one, he got mastery at least at 85%. The two were a little lower, like 60 and 40. So they didn't reach criteria. Okay. So results, there was a demonstration of effect of video modeling on imitation skills in these all four cases, but two mastered and two were they had slow increase on imitation skill, but they had made some increase. And then generalization, two participants, Kimani and the other one, Kimani and Vihan, they reached mastery criteria during generalization without training, and 4 new targets were used. Trial to criterion, it was a measure to determine the number of responses or opportunities to achieve mastery criterion. And 6 targets for Kimani and Vihan, they got faster acquisition, and 4 targets for Rihan and Solan, they were making slow progress. So results show that fast acquisition on 2 targets on imitation with object and 1 without object for both Kimani and Vihan. So the 2 target with the object was drink from a cup. So I will pretend to drink. No, it was in the video. So in the video, I had pretending to drink. And then second was stirring spoon in a cup. So they did well on those. So after this, I did a comparison between the MIS pre and post test, the Moto imitation scale, and that indicated that there was a gain in imitation skill for all participants at the end. Although there was slight increase in the 2 who didn't have too much of attending skill. Result clearly showed that gain in imitation skills. Kimani, at the beginning, he had 14 by 32. At the end, he had 32 by 30, 31 by 32. And the rest, they had made progress. All of them had made progress. So I had collected some IOA data. I had set it to 80% of the study, and another colleague of mine, he had collected some data on IOA, and he had his results were at 89% correct. Treatment integrity checklist completed daily for a week, at least 10 sessions at 98%. So I wanted to make sure that I did everything as needed, setting up equipment, getting attention, show video and pause, verbal instruction, do same, deliver correction and prompt incorrect response, deliver reinforcement on FR1 followed by FR3, and recording all the data. So after this session, after the treatment was over, I did a debriefing with the family and staff in person at the school. So parent and principal and the staff were present, and verbal consent was obtained for the group meeting. Question about ASD and ABA, there were plenty of those questions from the families. They were so anxious. They all said that they were satisfied with the study. There was no adverse effect reported, whether the child was getting so obsessed with the phone and all that. Social validity questionnaire, the questionnaire was discussed, and parent were happy with that, and they said that it is good. They would want their children to learn through imitation skill. Social validity. So during the debriefing session, short validity questionnaire were discussed in local language, and all parents agreed that it is important for the children to learn imitation. Whether independent imitation increased, one family reported that her child is watching video and imitating dancing. In fact, they never used to get interested in any of videos and everything. satisfaction after intervention and looking forward to get appropriate support. This is what the family wanted. But then when I left there, I tried to keep in contact with them. I created a group for these 4 families, but they didn't really pay attention to that. And then one parent reported that her child is seeking her phone more often than now. Okay, so discussion. Results demonstrated that there was an increase in imitation skills. 2 participants reached mastery in all targets and 2 did not, but there was a slight increase. And this study suggests that video modeling can be effective in teaching video imitation skill. And it also supports findings from previous video modeling studies teaching various skills. It can be both effective and time efficient, cost effective. And then the children, like, they were reacting to the video better than with me directly with them one-on-one. So video modeling can be effective anywhere in the world, whether location, any part of the world, culture, language, socioeconomic status, access to technology and all that. So we can do video modeling anywhere. So what I observed was 2 participants with good attending skill reached mastery for all targets. 2 participants with limited attending skill did not reach the mastery skill. This leads us to believe that attending skill is an important prerequisite. So probably we need a little bit more intervention, a little bit more experiments on attending skill. And then observation 2, participant did better with imitation with an object than gross motor. So if we say wave, so like in my video, somebody is going to wave. They did better with, say, tap the table with a spoon or stir the spoon in the cup. So they did better with object than gross motor. So there was some limitation in this experiment. For me, there was a lack of professional support and space. I was on my own. Space was limited. Sometimes other people were coming in and out, so disturbing the child or distracting the child. Space time between sessions. So I had 4 kids in a day, and I had 2 sessions each one. So one in the morning and one in the afternoon. So there was not enough time between sessions. Need enough time to contact authorities in the host country to get all information before the study. I had to run around to be able to get some information, get some consent and all that. And then we need to use proper experienced person in technology creating videos. My videos were clear and everything. There was no sound, and I had a white background and everything. It worked well, but if something like somebody more experienced would have done that, so it would have done back to back. I was doing one video and then pause, and then I do the next one. But with an experienced person, he could have done one and then back to back, second and third and all that. So it would have been easy for me to show them the video. So implication of the research finding, imitation is an important prerequisite skills. It helps acquire other functional skills through observation. Imitation's difficult for some individuals. They need more extensive training, and it is beneficial to individuals in underprivileged society. So instead of doing like one-on-one training in imitation, with the video modeling, it goes faster. Okay, so future direction, I would suggest that limited studies demonstrating attending skill is an important prerequisite skills for imitation. So we need more pre and post treatment individually. We need to use a between group methodology to allow for comparison between attending skills and without attending skills. And then extending studies to rural places and have that have prevalence in autism and skill deficit in various domains. That would help to teach these children some other skills. So in summary, effective video modeling is effective in teaching imitation, regardless of region, culture, and language. Attending skill is maybe an essential feature to consider when teaching skills. Therefore, training in attending skills before teaching imitation skills via modeling is important. When teaching school readiness skills such as following direction, one-step direction, would young learners with some or no imitative abilities learn faster when instruction are presented in a video modeling format? I would say yes, but we need to do more research on this. And again, like Temple Grandin said, there is a need to put a lot of more emphasis on what a child can do instead of what he cannot do. So this was my presentation. I have references, and thank you for listening. And if you have any questions or correspondence, you can contact me in the number email below. And I'm sorry if my voice, because I've been sick for so many days. And that's about it.
I have a quick question about just the severity of autism. It can be mild to severe. Is there like a criteria where you feel like video modeling works the best?
Right. So severe will be like the child has, like I said, no attending skills or limited attending skills and has a lot of behaviors. So challenging, the behaviors are so challenging that the child doesn't learn. And then it takes longer for the child to learn some skills. Even say the child is nonverbal and we are teaching him vocal, we are teaching him echoic. So even saying ah, we say ah, that also the child cannot say. So they are nonverbal, they don't pay attention. That is more severe, but it is, some of them are, we call that higher functioning, but we are not allowed to say higher functioning anymore now. The child has more skills, the child has, he can learn faster, but even the higher functioning kids, they have challenging behaviors. They will be like, when they are not happy, they will throw themselves on the floor and cry and all that. So I'm working with one of my families right now. Some of them have like other disabilities, like physical disabilities plus autism, and it makes it more difficult. But overall, like, if the child is able to learn skills, but we have to do a lot of training. Even those with higher functioning, they will learn faster, but they will learn faster, but even then we have to continue doing repetition. So one goal, one target will be like we do 5 or 10 trials in a row, and then we will do mass trial after that. Kids with severe autism, they learn. It's not that they do not learn. They learn less fast, and then sometimes it will take like 6 months to learn one skill. And parents are really not, they're very frustrated because their children are not learning. They need to learn how to put their shoes on, put their shirts on. So I've been working with the children for the last 25 years. And I started as an instructor therapist, that is working one-on-one with them. And then now I'm consulting, and I am also a clinical supervisor with some of them. And I have seen various types of autism, like many levels. So now the diagnosis says that the child is on level 1, 2, and 3. 3 is the more severe. And
Thank
we do
you. I
assessment.
thought they used a number scale now.
Sorry?
I thought they used a number scale now, but I couldn't remember. So 1, 2,
The
or
number
3.
scale is like level 1, not really number scale, but level. Level 1, 2, and 3. 3 is more severe, 1 is less.
Thank you.
Okay. Thank you so much for listening to me, and hopefully I'll go and rest a little bit.
Thank you for presenting. We appreciate your time.
Thank you,
We're
Brenda.
checking in real quick to see if Dr. Novick is here. I don't see his name, which means we're going to move to our last speaker for day 3, Dr. Zinia Mohammed Murali from the United Kingdom, a pediatric junior clinical fellow. And she's going to be talking about it. I'm going to totally mess this up, but is it Kaposiform hemangiopendothelemioma? I'll let you do
Very
that.
close.
It's a
It
case
was
report.
very.
I'll let you take over. Thank you.
Hi, can you see and hear me properly?
We can see and hear you. Yes.
Okay, I'm just going to share my slides. Please tell me if you are able to see it.
It says you're sharing, and now we can see it. Yes.
Perfect. So hi everyone, my name is Zinia Merali, and I'm a pediatric junior clinical fellow at the Royal National Orthopaedic Hospital in the UK. And I'm very excited to be here to present something quite unusual. First time I've seen this case, and it is quite rare. It is Kaposiform hemangioendothelioma. What I'm presenting is not the typical case presentation that you see. It's an unusual case presentation, and I'm also going to highlight the importance of biopsy in diagnosis. So what we're going to go through is just the introduction, the background of Kaposiform, and then we'll move on to the case review, go through the timelines that the patient went through, and their key investigations, their key differentials as well, diagnosis management that was relevant for them, and then also go through some imaging modalities and discuss what we saw in this patient versus what we maybe should see in a typical case, and then finish with some take-home and learning points. So what is Kaposiform hemangioendothelioma? It's a locally aggressive vascular tumor that most commonly affects infants and young children. Histologically, it's characterized by spindle-shaped endothelial cells and capillary hemangioma-like lymphatic vessels. And on the right, you can see this is a very typical picture of what Kaposiform looks like. It most often is on the extremity, as you can see, spanning the shaft of the extremity with a characteristic color that you can see in this picture. And I'll take you through this a bit later on as well. This is not the picture of the patient. This is just what a typical one looks like. So according to the International Society for the Study of Vascular Anomalies, Kaposiform falls under 2 groups. One is under the group of vascular tumors, and then it also falls under the subgroup of locally aggressive or borderline behavior. And most commonly, it affects the skin and subcutaneous tissues, but more rarely, it can also occur in deep tissues like the retroperitoneum. And in about 70% of patients, it's often associated with something called Casabat-Merritt phenomenon. It's a rare consumptive coagulopathy, and it's a life-threatening disorder that mostly affects infants, where the rapidly growing tumor traps platelets, and then it leads to thrombocytopenia and other clotting issues. And you can see from this subgroup as well, some of the differentials for this is composite hemangioendothelioma, Kaposi sarcoma, retiform hemangioendothelioma, and Dapska tumor. So what is the prevalence? It occurs with an estimated annual prevalence of 0.91 and an incidence of 0.071 per 100,000 children. And for Kaposiform, there are almost no prospective studies available. So most of the information that comes is from case reports. And that means that asymptomatic or atypical cases that can be and are misdiagnosed as other vascular anomalies or atypical variants shows that these figures are actually higher than reported. And in approximately 90% of cases, Kaposiform is more common in children less than 1 year of age. But there are 2 peak occurrences that occur in childhood. The first peak occurs within 1 year of life, where some can even be diagnosed at birth. And 90% of cases are evident within this first peak. but it can also occur in the toddler age group. And occurrences in the toddler age group are a bit more rare and even more rarer in older age groups past this. But the median age of presentation is between 2 to 6.5 months. So what is the typical presentation? The most common clinical presentation is a characteristic violet cutaneous lesion that will infiltrate the underlying skin on the extremities. About 12% of patients will lack cutaneous involvement. So 12% from an already rare cohort is a very small number. A majority of the lesions will occur in an extremity, and then you see some in the torso and some in cervicofacial regions. But patients without the classical cutaneous symptoms in atypical anatomic locations tend to be older in age, as seen with the case that I'm presenting. So this is just a few pictures of what the common presentation looks like. More often on the extremity, as you can see, it spans pretty much the whole shaft of the extremity. It has a very characteristic color, and over time, the limb does, or wherever it affects, does tend to swell. And you can see some in the cervicofacial regions as well. So these are the typical presentations that you will see. So why are we talking about this? One, to describe what an atypical presentation looks like, to emphasize the diagnostic challenges in distinguishing this from other lesions, highlighting the critical role of biopsy in confirming diagnosis, and also discussing the implications of delayed diagnosis on management and outcomes. So case overview. The case that I'm going to present involves an 11-year-old male, which was an unusual age group for Kaposiform. The lesion occurred outside the typical locations that you've just seen, and it also mimicked other musculoskeletal conditions that led to a diagnostic delay. This emphasizes the need for considering Kaposiform in atypical cases, so we need to be putting it a bit higher in our differential lists, and also to highlight the importance of biopsy in achieving accurate diagnosis. So we'll go through the case now. So the patient presented with a 6-month history in February 2020 of pain and stiffness in the right elbow. The pain was stinging in nature and only increased particularly when the elbow was bumped. It was relieved by NSAIDs, but otherwise the pain was not present. The stiffness was more in the morning and resolved throughout the day. On examination of the elbow, there was small spider telangiectasias noted over the skin with significant wasting of the right biceps and triceps muscle and swelling over the proximal forearm, but no other discoloration. He had a 30-degree fixed flexion deformity of that elbow and an additional 70 degrees of further flexion. But he also had restricted pronation and supination of that forearm of 40 degrees in motion. An MRI was done at the time that revealed a cystic lesion and soft tissue edema. And it suggested there was a concern at the time for a malignancy, but a CT scan was also done at the time, which suggested an enthesitis with erosions at the insertion of the distal brachialis tendon and on the volar surface of the proximal ulna with osteopenia. So provisional diagnosis at the time was made for a chondral lesion and chronic recurrent multifocal osteomyelitis. So the patient was initiated on a treatment plan of pamidronate, but this only offered very minimal relief for the patient. So in September 2020, there was a follow-up MRI was done that suggested enthesitis, and a plan for biopsy was made. But because the MRI suggested a very clear enthesitis, without a definitive focus, but it tied in with the CT scan results, the planned biopsy was actually deferred. So the patient was started on a wean down therapy of prednisolone, followed by sulfasalazine. And 4 months after starting the sulfasalazine, there was mild improvement in pain and stiffness, but he still had the fixed flexion deformity with difficulty in lifting heavy objects. 9 months after commencing the sulfasalazine, a routine MRI showed worsening of the edema with an increase in erosive changes. And after a year of sulfasalazine, that was September 2021, there was no noted improvement in joint mobility. So the patient was actually started on oral methotrexate now, and adalimumab was concurrently introduced. And after some time, the oral methotrexate was changed to subcutaneous for increased efficacy. But despite this, there was still limited clinical improvement. And an MRI done in the beginning of June 2023 was also non-reassuring. It showed findings of predominantly, again, an enthesopathic condition. At the time, it was thought to be enthesopathy-related arthritis with additional common flexor tendon enthesopathy for him. And at this time, a biopsy was actually performed, and the biopsy confirmed Kaposiform hemangioendothelioma of the proximal ulna. Surgical management was considered, but it was deferred due to interference with the growth plates in this particular age group and the wide range of resection that was needed to get negative margins. So sirolimus therapy was considered for this patient at the time. Surprisingly, while sirolimus therapy was underway, a repeat follow-up MRI was done in September 2024, which showed spontaneous reduction in tumor size. And what happened was, after a big multidisciplinary team meeting, the sirolimus was withheld because the symptoms had stabilized, and a watch and wait approach was actually considered at the time. And his most recent MRI showed stable appearances, with no disease progression. It also showed significant atrophy of the right elbow and upper body of the affected side, but at that time it was suspected to be more from disuse rather than the progression of the Kaposiform. And the patient remained functionally stable on methotrexate and folate, which was eventually completed, and a watch and wait approach was opted for. So what you can see here is his initial X-ray from February 2020. And you can see that the bones appear dysplastic. There's generalized osteopenia around the elbow joint. There is also irregular thickening of the lateral cortex of the proximal ulna. There's no joint effusion or destructive lesion identified here. So this is when it was thought that the appearance could be due to a chronic hyperemic condition or chronic recurrent multifocal osteomyelitis, also called CRMO. And if you look at his initial MRI here, it also shows edema in the proximal ulna and soft tissues with mild muscle atrophy. But again, there's no effusion or no significant joint abnormality. So let's go to his key investigations. It started with the blood test. So his complete blood count, his kidney function test, his liver function test, autoimmune markers, inflammatory markers, HLA-B27 were all negative. So MRIs were done, and his latest one showed stable lesion with tumor size reduction, no progression or no new involvement, unlike earlier. His biopsy in June 2023 confirmed vascular tumor consistent with Kaposiform hemangioendothelioma. It showed spindle endothelial cells forming glomeruloid nodules, fibrin thrombi, and hyaline globules. But this was also paired with immunohistochemistry for him, which was positive for CD31 and CD34, which are cell surface markers that are highly specific for endothelial cells. ERG was also positive for him, which is present in endothelial cells and is a good marker for vascular tumors. He was also positive for D240, which is a determinate marker for Kaposiform hemangioendothelioma. However, he was negative for CFOS, FOSB, H33, and G34W. So what were the key differentials that were relevant for him? One was the CRMO. This was initially suspected due to the bone pain, the cortical erosions, and the edema. But he also had absence of inflammatory markers. He had no autoimmune markers positive as well. And then there was also no response to pamidronate infusions, which ruled it out. Chondral lesion was also thought about, And this was due to the cystic appearance on his initial MRI, but there was a lack of cartilaginous tissues and lack of any vascular tumor cells, so that was ruled out as well. His top differential was enthesitis and enthesopathy, and this was due to the consistent MRI findings, his CT scan findings, but he also had lack of response to immunosuppressive therapy, so that was eventually ruled out. Of course, soft tissue sarcomas were also thought about given the aggressive imaging, the initial progression of the cystic appearance in the MRIs, but this was ruled out by a CT scan as well and the biopsy. And the patient also did not present with any B symptoms or any red flag signs. So what was the final diagnosis and management plan for this patient? Final diagnosis was Kaposiform hemangioendothelioma, which was confirmed with biopsy. Supportive management from the beginning to the end was a multidisciplinary team approach for the patient. He underwent physiotherapy, occupational therapy, and is still undergoing it till today to help with the range of movement in the right elbow. But he also underwent counseling because of the toll that the disease took on him throughout all those years. It was the disease uncertainty. It was not knowing what the treatment plan is, if he'll ever be better, if he'll ever get the range of movement back in his hand. So he's still undergoing counseling as well. Pharmacological management. Initially, the mainstay was analgesics and NSAIDs, and the NSAID that worked best for him was naproxen. And then the pamidronate infusions, which was eventually progressed to the methotrexate and folic acid, which was there for a while, the adalimumab concurrently, and then eventually, while sirolimus was being considered, the final management plan for him was a watch and wait approach, for which he's doing pretty well on it at the moment. So the diagnosis of Kaposiform requires clinical, it needs imaging, it needs hematological, but it also needs pathological efforts. And despite the availability of all these modalities, you can see that the wide spectrum of these clinical presentations and case rarity may still not ensure a definitive diagnosis. For small and superficial lesions, ultrasound can be the first choice of assessment. MRI with and without gadolinium enhancement can indicate the extent of the lesion, but also give you what the response to treatment is. And the MRI findings in our case were not consistent with the typical results seen, as it showed presence of edema surrounding the joint associated with muscle atrophy, which are features that are more consistent with enthesitis or enthesitis-related arthritis rather than Kaposiform. But the typical MRI features for Kaposiform involves the appearance of irregular soft tissue masses with ragged edges that is capable of invading the surrounding structures. If you do a contrast-enhanced MRI, it will show commonly persistent enhancement of the lesion surrounded by abundant vasculature. These characteristics are not consistent with different age groups and rare locations, as we can see with our case. It's also important to note that after diagnosis, interval MRIs are very integral in monitoring disease process and guiding treatment. Immunohistochemistry is also extremely important. It shows endothelial cells that are positive for CD31, CD34, which we saw was positive in our patient as well. Vascular endothelial growth factor 3, which was not positive in our patient, and D240, which was positive in our patient. But what we need is a combination of your histopathological and immunohistochemistry to confirm diagnosis, because you can still have conflicting results. What is the gold standard? As we've seen from this case, the gold standard is biopsy, and this should be considered for atypical clinical manifestations, especially when diagnosis is still uncertain. Biopsy results in our case showed vascular tumor composed of small, multiple glomeruloid nodules of ovoid cells that surrounded the capillary vessels. It contained the fibrin thrombi and hyaline globules, but was also mixed with osteoclast-like giant cells with fibrovascular stroma, which made the diagnosis a little bit more challenging here, because the hallmark biopsy will show defined and rounded confluent nodules composed of spindle endothelial cells. So it was pairing the biopsy and the immunohistochemistry that gave us the diagnosis. The treatment for this patient ideally would be sirolimus is widely used at this moment with vincristine, but more for refractory cases. The first line is either a wait and watch approach, steroids, which was considered for this patient and trial, and then surgery, which depends on age and other factors as well. So what are the take-home points here? Kaposi form is rare, it's locally aggressive. It happens most common in infancy, but can occur much rarely in older children. It did not happen in this patient, but we mentioned earlier that Casaback-Merritt phenomenon does happen in 70% of patients and is a very life-threatening disorder. Atypical presentations are diagnostic challenges, especially when we don't see the classical symptoms. Imaging findings, like in our case, can be misleading. They can mimic other inflammatory conditions or other enthesopathic conditions. Biopsy till today still remains the gold standard for diagnosis and needs to be pursued much earlier, especially when the diagnosis is uncertain. This needs to be paired with both immunohistochemical markers as well to confirm diagnosis. And follow-up MRIs are essential for monitoring lesion stability, and treatment response should be done about every 6 months for patients presenting with this. So what do we learn from this case? Early biopsy for this case could have led to a faster diagnosis and targeted management. What was not done here was that a biopsy was deferred because of mimicked other conditions, and also due to the psychosocial state of the patient, and it took quite a long time to convince the patient to do a biopsy again. A multidisciplinary approach improves outcomes, which was done for this patient. Non-classical presentations need a very high clinical suspicion to avoid these kind of delays. Sirolimus therapy can be effective and is still an option for him now if the watch and wait approach does not work in the future. And patient-centered management is really, really important with regular imaging to guide decisions, even in rare diseases, because ultimately the management should be patient-centered management. These are the references that were used, and thank you.
Thank you for that case study. Are there any questions? We appreciate your presentation. Thank you to all the speakers for their remarkable insights and contributions. The work continues to inspire collaboration and progress in global pediatric and child health. That's the end of our day 3. Thank you for everyone for attending. And please look into the other conferences offered by this wonderful organization. Oops. That ends our session of day 3. Everyone have a great day. Thank you.